but most of the trial do not show any differences in the incidences of UTI. But from our clinical experience, we have seen some increase in urinary tract infections while patients are on SGLT2. The genital mycotic infection is an important complication, and if it occurs, it's always better not to re-initiate an SGLT2. The bone fractures was initially seen in the CANVAS trial and later in the DAPA-CKD trial because of the increased phosphate reabsorption associated with SGLT2 use. Limb amputation was initially a concern in the CANVAS, but none of the trials in further has not shown any increase in limb amputations. AKI risk, we always consider there is a risk of AKI because of diuresis. There can be a pre-renal component and there can be a pre-renal AKI. Majority of the trials, including the meta-analysis, have not shown an increase in the risk of AKI in SGLT2 use. So in a nutshell, one small dip in GFR happens, but that's a big leap for prevention of diabetic nephropathy. As I already mentioned, this hemodynamic effect of SGLT2 and RAS is similar, but RAS acts on the efferent arteriole, causing vasodilatation and decreasing the intraglomerular hypertension, and SGLT2 causes efferent arterial vasoconstriction and thereby decreasing the intraglomerular pressure. And as we can see here, with RAS blockade alone, the progression of kidney disease per year or the decrease in GFR per year is 4.6 ml, whereas with SGLT2 and RAS alone, it decreases drastically by 1.85 ml per minute and delays ESKD by years. So that is the advantage of SGLT2. So this is the KDIGO guidelines. We can start SGLT2 with it now with the cutoff of even eGFR of 20. We can start if the GFR is more than or equal to 20, and high priority if there is proteinuria. And potential contraindications include genital infections, ketoacidosis risk, foot ulcers, and immunosuppression. And not on volume depletion, where volume depletion, especially in tropical countries like India, where there is high risk of volume depletion, dehydration, and risk of AKI, always consider the diuretic. If the patient is on diuretic for cardiovascular issues, always try to consider a diuretic dose reduction when starting SGLT2 inhibitors. Now, inflammation and fibrotic pathway. So we have come across the hemodynamic factors, we have seen the metabolic factors and how we deal with hemodynamic and metabolic factors. Now comes the inflammation and fibrosis, how to tackle the inflammation and fibrosis associated with the diabetic nephropathy. So here comes the role of finerenone, the newer selective mineralocorticoid receptor antagonist. So how it acts or how it differs from the steroidal MRAs, we have to see this slide. The mode of antagonism, finerenone is more potent and more selective. And the tissue distribution for finerenone is equal for kidney and the heart. And one of the most important thing is it has got no active metabolites. Half-life is only 2 to 3 hours. So when there is no active metabolites and the short half-life, always there is a risk. The complication risk is very minimal, especially hyperkalemia. So theoretically speaking, finerenone is supposed to have less hyperkalemia than spironolactone and eplerenone. And it has got a strong inhibition on the inflammation and fibrosis where compared to the steroidal MRAs. Sexual side effects are low, or even not, it's not been seen, and the effect on BP is only modest. So thereby decreasing the risk of hypovolemia and pre-renal AKIs. So this is how finerenone differs from the steroidal MRAs. And this is the Fidelio DKD trial where direct primary composite renal outcomes were assessed. And we can see that there is a significant reduction of primary composite outcomes at 2.6 years with the kidney failure of more than 40% decrease in eGFR, or death from renal causes was significantly reduced with a hazard ratio of 0.82. So definitely Fidelio trial was a positive trial which showed finerenone protects the progression of kidney disease beyond RAS blockade. And this is a Figaro trial. It was a primary cardiovascular outcome trial, and the secondary outcome was kidney disease. And that also showed a significant decrease of or prevention or significant decrease in the progression of diabetic kidney diseases. And then comes the Fidelity pre-specified pool analysis. It's a pool analysis of Fidelio and Figaro DKDs. We can see that there's kidney composite outcomes were decreased in the finerenone group, and with a hazard ratio of 0.77, almost 23% risk reduction, and that's statistically very significant. But here we can see that the risk of hyperkalemia definitely, even though theoretically the risk of hyperkalemia is less, there is a slightly increased risk of hyperkalemia in finerenone group because of the mechanism of action of this drug. And the treatment discontinuation due to hypokalemia was around 2% in this very large trial of 13,000 people. So an interesting aspect in the fertility trial is renal outcomes on patients on SGLT2 inhibitors. So when the patient is on RAS blockade and SGLT2 inhibitors, when we add up finerenone, is there an added benefit? Obviously, we can see in the forest plot here, there is an obvious benefit, but the evidence is not strong because we need further studies to make this more stronger studies to confirm this aspect, because patients already on RAS blockade and patients already on SGLT inhibitors may not be much effective than those patients without SGLT inhibitors. That's why the ADA guidelines has mentioned in patients with CKD who are at increased risk for cardiovascular events or CKD progression or are unable to use an SGLT2, finerenone is recommended to reduce the CKD progression and cardiovascular events. It's a type level A recommendation. And finerenone, initiate if only the potassium is less than 4.8. We can start at 10 milligram if it is between, the GFR is between 25 to 59, and 20 if GFR is more than 60. And continue if it is the potassium is maintained. If potassium is more than 5.5, halt finerenone and restart only if the potassium is less than 5. And a small note on incretins. I'm not going to detail because of the time concerns. So incretin-based therapy decreases blood glucose, decreasing blood pressure, increase antioxidants, and it has got an anti-inflammatory property. But coming to the bedside, the GLP-1 receptor agonist has shown some benefit in reducing the large scale reduction in risk of albuminuria and composite renal endpoint outcomes. But DPP-4 inhibitors, the meta-analysis does not support a reduction as of now. And always there is a concern for diabetic retinopathy progression when using DPP-4 inhibitors, and a little unclear association with the GLP-1 receptor agonist. So GLP-1 receptor agonist needs further trials, more meta-analysis and more randomized controlled trials to make sure that it has got an added benefit in diabetic nephropathy. So this is again the almost similar mechanism of action by reducing the inflammation and oxidative stress and causing natriuresis. This GLP-1 agonist may have a beneficial effect in a long run for diabetic nephropathy. So these are some of the few drugs that has been already, that's ongoing trials happening on cevilamar, pentoxifylline, cilostazol. These are few of the molecules that we commonly use for some other causes. So sometimes it may be helpful for diabetic prevention of diabetic nephropathy progression that is yet to be unfolded by the ongoing trials. And the endothelin receptor antagonism with atrasentan and besentan, and also by pirfenidone, where we use as an antifibrotic agent in pulmonology. The effect of pirfenidone on preventing the GFR decrease. This has been this is another ongoing RCT. And once this RCT comes, we may be able to find new and new molecules for this prevention of these diseases. So in nutshell, the first line therapy now proven, it's metformin. SGLT2 is the first line therapy, then RAS blockade and statin. And goal-directed therapy, again with GLP-1 receptor agonist, and comes the non-steroidal MRAs. And coming to, this is in nutshell the KDIGO guidelines, where the first line therapy here is SGLT2 and metformin for diabetes, and GLP-1 receptor agonist if needed to achieve an individualized glycemic target. It's not for the diabetic nephropathy. It's mainly aimed at decreasing the, improving the glycemic targets. And RAS inhibition with maximum tolerated dose if there is hypertension. And the second line can be a non-steroidal MRA if ACR is more than 30 and normal potassium. And other antihypertensives and steroidal MRAs for control of hypertension, and moderate intensity statins for cardiovascular risk benefits. So this is in nutshell now the treatment of diabetic nephropathy. Thank you for your kind attention.
Thank you, Dr. Sarang, for wonderfully taking through diabetic nephropathy beyond ARBA and AC inhibitors. Now, I have a question in the chat box here. Dr. Shabir has asked, please give your thoughts on the role of SGLT2 in the patients on dialysis. Would they be approved in future? So is SGLT2 approved in patients who are undergoing dialysis, diabetic kidney diseases?
As of now, the recommendation is to stop SGLT2 when the patient goes in for renal replacement therapy. But the problem with dialysis patients is that The SGLT2, the mechanism of actions happens in the tubules. So this molecule has to reach the tubules for the mechanism, the action of this drug to happen. So in patients with no residual renal function, or whether it's a very minimal residual renal function in dialysis, they may not have much role. And we don't know what's going to happen in future, but as of now, there is no indication for SGLT2 in dialysis or even in renal transplant.
Thank you very much for that. There are no further questions in the chat box, but just to continue with one or two questions, is microalbuminuria reversible?
Previously, it was considered to be once you get microalbuminuria, it's always a downhill course. But nowadays, it has been proven beyond doubt that if we have adequate control, some patients may have reversal of microalbuminuria, especially with RAS blockade and the newer drugs. It's not like once you develop microalbuminuria, it's an end. It's the starting of a diabetic nephropathy spectrum. But always there is a chance for reversal of albuminuria in the early diabetic, of course.
Yeah, and we know that diabetic patients, almost 70% of them do have hypertension concurrently. And invariably, they will be on an ARB for sure for controlling of hypertension. Now, when do we withdraw an ARB in patient with diabetic nephropathy? Is it the 30% rule, or is there a specific cutoff baseline? And
ARBs, there is no definite GFR cutoffs. And we can't say you have to stop ARB or RAS blockade once the GFR crosses beyond a limit, because always there is a scope for prevention or the further progression of kidney disease with RAS blockade. Definitely, as I already mentioned, if there is if on initiation or on increasing the dose of RAS blockade, if there is more than 30% increase in creatinine, then we have to rule out other causes of AK. We have to rule out other causes of worsening GFR. And if none of this is there, then we have to think of stopping or ARB in that case. But other than that, there is no GFR cutoffs except for the risk of hyperkalemia.
Dr. Vijay, do you want to add on to it something? We are almost through the first topic.
Dr. Murali, there are a couple of more questions in the chat box. Can you please?
I didn't, just a minute, I'll just go through it. Yeah, three more. Yeah, I just. Yeah, Dr. Vijay, do you want to add on to it? I'll just pick up those questions in the chat box. Just a minute.
No, sir. It was a very nice talk. So I don't have anything to add, sir. Thank you.
The one question is that, is there any significant difference with different SGLT2 inhibitors? So virtually they are asking about all the three which we have here.
Okay, so actually, the benefits of SGLT2 inhibitors is a classic, and so it's almost all the SGLT inhibitors what we have mentioned here, the dapagliflozin, canagliflozin, and epagliflozins. These gliflozins, the benefit in kidney disease is the class effect, and there's not much of a difference between these two. We can choose whichever we feel like.
Yeah, there is one more question from Dr. Joe. Can antiplatelet therapy improve long-term renal outcomes? Is there any evidence for that?
There is no hard outcomes, especially in proliferative diabetic retinopathy. So what we see, the proteinuric diabetic kidney disease, there is not much of a role for antiplatelets. Or I don't say there is no role, but there are no proven benefits, or there are hard benefits with antiplatelets. But in atherosclerotic diabetic nephropathy spectrums now includes the atherosclerotic renovascular diseases also. So in that case, because of the atherosclerosis and the progression of kidney disease, antiplatelets might have a role, but there are no RCTs or large meta-analysis that supports this.
Yeah, I'll just take the other two more questions, and after that we'll wind up. This question is, what about newer calcium channel blockers like venidipine in reducing proteinuria?
There has been a lot of small trials that shows that these newer calcium channel blockers like esenlidipine, benlidipine, all these causes reduction in proteinuria. But as of now, other than the RAS blockade, the major antihypertensive that has got a beneficial effect in reducing the proteinuria is non-dihydropyridine calcium channel blockers like the diltiazem and verapamil. So that's the calcium channel blockers that's already been have randomized control, or rather been have a data on reduction in the proteinuria. But with newer CCBs, there are small trials that show the reduction in proteinuria, but we need more evidences to believe it, or we will need more evidences to make sure that this is actually a reduction in proteinuria.
Final question is usefulness of keto analogs.
Keto analogs, the keto analogs is actually a supportive treatment in the prevention or preventing the progression of kidney disease. It's not like diabetic kidney disease, nor kidney disease. So we are basically shifting the energy metabolism pathway from the glucose-directed pathway to the ketogenic pathway. That's the basic mechanism of keto analogs, and there has been some evidences for that. And the KDIGO also recommends alpha keto analogs for the prevention of progression of kidney disease, but it has got a low level of evidence for that.
So thank you very much, Dr. Sarang, for elucidating in detail about nephroprotection and beyond ARBs. And Dr. Vijay, do you want to add on anything, or we can wind up this session?
Yes, sir. Can we?
Yeah.
Thank you, sir.
Yeah. So that we know that examining albumin is one of the cheapest and the easiest test to get into, find out whether there is any micro complications, so we all should, being diabetologists, should make it mandatory that microalbumin becomes a part of our testing, apart from the routine fasting PPBS, creatinine, and HbA1c. With that, I thank you all. Thank you, Dr. Sarang, and over back to Dr. Arjun.
Thank you for giving me this opportunity.
Thank you, Dr. Sarang, for that enlightening session. Thank you, Bijoy sir and Murli sir, for taking your time and sharing the session. We move on to the next session. Before that, there is an announcement. After the second talk, there will be a screenshot which should be taken for the TCMC credit purposes. So after the talk, gestational diabetes, old age versus insulin current status, there will be a screenshot being taken. Then after the fifth talk, management of inpatient hyperglycemia, how to treat and how much to treat, there will be a screenshot. And after the last session, there will be a screenshot. So participants will be asked to be present and take switch on their video. So we move on to the next session. For that, I invite the chairpersons, Dr. Anita Nambiar madam and Simi Kurian madam, and I'll introduce the speaker. The speaker is Mrs. Akhila Bandarkar, Dr. Akhila Bandarkar. She is a consultant endocrinologist at KS Hegde Medical Academy, Mangalore. She has special areas of interest which include obesity, thyroid disorders in pregnancy, women's health, and metabolic bone disorders. Over to the chairpersons to introduce the topic and start the session.
Good morning, all. First of all, let me thank the organizers for giving me this opportunity. I am Dr. Simi Kurian from the Department of Gynecology, Government Medical College, Kannur. And my co-chairperson is Dr. Anita Nambiar from Kochi. As we know, the prevalence of diabetes is increasing in our country. So also the prevalence of gestational diabetes also. And the control of blood sugar is very important, as it can lead to significant fetal morbidity as well as mortality. And regarding the control of blood sugar, sometimes we are often confused whether to start with oral hypoglycemic agents or to start with insulin. Now, let us hear from Dr. Akhila. What is the current status regarding the management of gestational diabetes, oral anti-diabetic drugs versus insulin? Over to you, Dr. Akhila.
Good morning, everybody, and thank you so much, madam, for that kind introduction to me as well as the topic. And foremost, I would like to thank the Kerala Rssdi organizers for having me here. I'll share my screen. Is it visible?
Yes, Akhila.
Yeah.
Lights are visible.
Yeah, right. So let's just have a brief look of what is the current status. So we have this patient Sherry who comes to us. So and she asks, in case I'm planning pregnancy, so for pregnancy related diabetes, so what would you suggest? Like, is it tablet or insulin? So her main concern is actually about the pharmacological therapy, but let's see if it's just the pharmacological therapy or more to it, and what about it in detail. So first of all, we'll tell her that the hyperglycemia does have adverse pregnancy outcomes as shown in many studies. But this is one of the important studies which is like a groundbreaking, which showed a continuous association of the maternal glucose blood levels with the increased birth weight and other complications. So most importantly, will stress that it's not just the pharmacological management. In fact, in the order of priority, it's the nutrition, medical nutrition therapy, and then the physical activity, and then comes the pharmacological management. So never to miss out this important aspect in the any patient with diabetes or GDM particularly. So since her question was predominantly in the pharmacological area, so we'll move on to it. So this is like a very controversial or a never-ending tug-of-war situation where we have a team OAD and we have team insulin. And in the team OAD, the main player is metformin, and also there's glyburide in Western countries. So let's see what FDA says about it. The FDA pregnancy category keeps both metformin and insulin in category B. So which means animal studies, yes, means animal studies have shown either no risk to fetus or animal studies have shown fetal risk, but controlled studies in pregnant women have no risk. So whereas glyburide, it comes in category C actually, but despite it such a vast use. Now, why metformin, first of all? Like, why not any other OADs, so many other OADs? Because the main pathology or pathogenesis of GDM or even otherwise diabetes in pregnancy is something to do with the insulin resistance that is created during the pregnancy, specifically in the mid-gestation period. So since metformin works in this area, that is, it increases the insulin sensitivity, or it improves the sensitivity basically, and reduces the insulin resistance. So this is one of the main reasons why like metformin had to be considered as one of the pharmacological agent for the therapy in this area. And meantime, it also gives us an advantage that it doesn't stimulate the fetal pancreatic cells to produce insulin. So because of which the risk of say neonatal hyperinsulinism and then the increased baby birth weight as such, so that may be less. So that's why this becomes a logical choice actually. But what about the safety? Because pregnancy is one area where we every time have to keep in mind that there are two persons we are treating at the same time with the placenta in between, and what happens to the child has to be taken into account. So the team OAD, the safety in first trimester actually. So the picture in the left-hand side that shows us the initial, the first trimester time. So during which the early embryonic cells, be it in the placenta or in the initial, like the zygote or the pre-implantation time. So during that time, the transporters as such are very less. So the transporter for metformin, say like the organic cation transporter or OCT, so that is particularly less. And even the mitochondria as such are immature initially. So because of which it may be safe in first trimester, like how it is also shown in some of the PCOD patients, it will be continued in the first trimester. So maybe the safety in first trimester is better. But as and when the fetal cells mature, so they increase the cation transporters, and even the mitochondria becomes more mature and more in number. So that time the safety is actually questionable, which needs to be studied in more of the studies, which we'll see now. So further in the molecular level, actually, so one of the main mechanisms in which the nutrients are sensed by placenta, that is the mTOR signaling pathways and other downstream targets. So all these are seen to be inhibited by metformin. So what happens because of this is the protein translation, cell growth, that will be affected. And because of which the nutrient restriction happens to the child. And we know very well what happens with the Barker's hypothesis. So that's the nutrient restriction in the intrauterine period that will lead to a reduced fetal growth. And in later time, it may predispose the child to some of the metabolic risks, say obesity, diabetes, cardiovascular disease. So all this is a possibility if nutrient restriction happens in the intrauterine period. On top of it, to add, we have some of the epigenetic modifications also being shown, specifically the histone deacetylation, phosphorylation, acetylation, methylation. So many other processes also contribute to epigenetic modifications. So the effect of which needs to be studied over a long-term studies. So what about insulin usage? So none of the currently available human insulin preparations, they have been demonstrated to cross the placenta. So mainly due to its molecular weight. But there are various studies which have shown in which insulin has been utilized in trials. So first of all, the RCTs. So insulin in the RCTs include the regular insulin, NPH, aspart, lispro, detamers, and even degludec in one of the studies. So recently that has shown non-inferiority to detamir in combination with the aspart. So because of which that also comes under our RCT now. While the insulin in the cohort study, that is the glargine, so that has an evidence, but it's mainly based upon the cohort evidence. And recently even the DCGI has given an approval, although we might need more RCTs in this area. So because of which the current status says that if patient is already on glargine, say for over diabetes, not for GDM per se, so maybe there's no harm in continuing it. But since Sherry is mainly asking about GDM, she's not overtly diabetic, so maybe we'll not consider initiating glargine as per the current evidence. And in case reports as such, Fias, glargine 300 and glulysin have been studied, but these are just the case reports. That's why it may not be that wise to start off as an initiation in pregnancy with these incidents. So then about the insulin, like how do we go about, and which type of insulin, how to start? So the best thing which actually mimics the physiology, that's the physiological rise of the glucose excursions, would be basal bolus regimen, which is even otherwise in any diabetic, more so in type 1 diabetic what we do. So if a patient has only postprandial hikes, postprandial spikes, maybe initially we can go only with the bolus regimen. So that is the yellow line here shows the glycemic excursion. And there's regular insulin, which is like a rapid acting. So that will usually compensate for the spikes or glycemic excursions. So, but whenever both the fasting and the postprandial values are high, then definitely it points towards the need for a basal basal insulin as well. So, and this is how it would work. Like the long-acting insulin, if you're choosing NPH, maybe we'll have to give it twice daily. Or if it's like detamir degludec, even once daily might be good enough. So they will compensate for the basal requirement, while the boluses will compensate for the glycemic excursions, keeping this line within the target. So, but what about, but what about the use of premixed insulin? So, though very commonly we see prescriptions coming with the premixed insulin, we very well know it doesn't mimic the physiological glycemic excursions and compensatory process for that. Maybe just for the convenience of the patient, we'll have to give it, but always the best option would be to give a basal bolus, maybe the four-time insulin prick. So a premix insulin would compensate it like this. So that is a regular or the rapid acting. So basically that component will compensate for the initial, the first meal of the day, like if it's breakfast. And then the lunch or the mid-meal, what comes. So that glycemic excursion is actually not clearly or as well taken care like how a regular insulin would or a rapid acting insulin would do. So the NPH component or any other protein-related aspect of it, now that would compensate to a minimal extent, but not as well as how it would do. And the second prick of premix insulin would again be given before dinner. So that would compensate for the rise in the dinner. But again, the basal may not be acting as long and as steady state as how otherwise an NPH or a detamir or a degludec would do. So that's why a premixed insulin is not a very good choice in pregnancy, but maybe for convenience or if patient is not at all willing, then maybe it can be considered. So, but what about the evidence? So yeah, so metformin versus insulin, we have good studies available now. So this is one of the trials called MIC trial. So in which women with GDM requiring medication, so they were recruited. And they were either randomized to receive a metformin or randomized to receive insulin. So the primary outcome, the primary composite outcome of this study, so that shows that the patients who were on insulin group, in the insulin group, so they had a significant risk of, say, hypoglycemia. That's any blood glucose level less than 28.8 milligram per deciliter. So this was actually more in the insulin group, while the risk for spontaneous preterm birth, that's below 37 weeks of gestation, that was clearly high with the patients in the metformin group. So this difference was seen in this MIC trial. So what about the secondary outcomes? So secondary outcomes which are considered were the neonatal anthropometric measures, say the birth weight, and then maternal glycemic control, maternal hypertensive complications, postpartum glucose tolerance, and acceptability of treatment by the mothers. So as such, in comparison of the secondary outcomes, there was no significant difference between the metformin and insulin group. And there was no serious adverse events with the metformin either throughout the study. And in fact, the acceptability of treatment was more for metformin. So if the women were asked if they would choose to receive metformin again, then they were willing for this rather than insulin. So clearly, any patient would choose a tablet over insulin anytime. But this is a catch that the supplemental insulin was required in about 46.3% of patients in the metformin group, which means the glycemic control aspect may not be that great. Specifically, this was seen in the patients who had higher BMI in the early pregnancy and higher baseline glucose levels. So now it feels like, okay, insulin could be better. But is it all? So let's see what other trials have to say. So this is like a meta-analysis of 21 randomized controlled trials, a systematic review, which included about 4,545 patients in 2021. So here we see a lot of points actually coming under the favor of metformin rather than insulin. So that's be it the maternal weight gain. So that was lesser, gestational age at birth. So even that was better, gestational hypertension, maternal hypoglycemia risk. So all of them were favoring metformin. Even the birth weight was lesser. Neonatal hypoglycemia was lesser, neonatal ICU admission was lesser, even the large for gestational age risk was lesser. So many points actually favoring metformin over insulin in this meta-analysis. So whereas the point that was favoring insulin was the risk of small for gestational age was lesser with the insulin. But as such, what the previous MIC trial showed, the chance of preterm birth, so that was not very different in this randomized control trial. So apart from that, even C-section risk was not much. There was no difference basically, and shoulder dystocia or RDS, perinatal mortality, all these things didn't show difference. So obviously at the end of this randomized control trial assessment or meta-analysis, we do kind of favor metformin. So it's very confusing situation. So is metformin better? So Sherry is confused now. What is the status? So we have one more study, which is a very good, again, systematic review and meta-analysis. So what does this say? So this is showing a lower incidence of macrosomia, lower incidence of NICU admission, less neonatal hypoglycemia. So all for gestation age was less, maternal weight gain was less, incidence of C-section was less. But at the same time, just like how the MIC trial was showing, the shorter gestational age at delivery was still there in this analysis also. And a decreased birth weight was again a risk in metformin group. So what's happening? So let's clear the air at the end of all this confusion. So what would actually give us a clarity is, the offspring study. So which if done on a long term will clear the risk of all whatever we are assuming, say the metabolic risk, the cardiovascular disease, all those things that would definitely be cleared with the offspring study. So this was done with a MIC-TOFU study. So this gives us an offspring data at 2 years. So this showed that in general, the weight or the total fat as such, it was not different, but what actually differed between the two groups at 2 years, the offspring data. So that was actually the subcutaneous fat at the level of upper arm circumference, subscapular skin fold, biceps skin fold. So these were the ones which were significantly better, significantly higher in metformin group. So with this, we obviously tend to understand that the metformin maybe favors the subcutaneous fat rather than the visceral adipose tissue, because we clearly see that there's no difference in total fat or abdominal fat with the DEXA in either of the groups. So maybe then metformin is better in, say, redistribution of the fat. So further, let's see what happened in the further follow-up study. That's a MIC-TOFU study. Now, this had basically the analysis done from two cohorts. One is from the Adelaide set and Auckland set. So children were assessed. So these were all the kids who were born to mothers with the diabetes in pregnancy. So the children were assessed at 7 years of age in Adelaide and 9 years of age in Auckland. So again, this comparison showed total and abdominal body fat percentage-wise, there was no difference actually. Even the metabolic measures, like say the fasting glucose, the insulin levels, so they were not different in the 7 to 9 years of age, percentage-wise. But then the Auckland kids who were assessed at 9 years of age, so they showed overall increased weight, increased BMI. So overall, they were larger in general. And the increased waist and the arm circumference, the triceps skin fold as shown before, specifically the waist to height ratio. So we know that it's one of the important risk factors for the CV risk. So waist to height ratio. And DIXA is the fat mass and lean mass, and MRI abdominal fat volume. So this is not the percentage, but in general for the overall the body mass as such, it was higher in the Auckland group. So this is the same thing actually shown here with the p values. So the weight, BMI, mid-arm circumference, the waist to height ratio, as well as tricep skin fold thickness, all of these were significantly higher in the metformin group in the Auckland cohort. So because of this, we know that metformin may interact with the fetal environment, like how we had seen in the initial slide. So a lot of molecular pathway effect was seen with metformin, although we still don't have a clarity of what it would leave in a long run, like say when the child grows to become an adult, 20 years, 40 years. We don't really have those studies, but we do get a clue that these children tend to be larger, clearly larger in comparison to those kids whose mothers were treated with the insulin. So it does influence some fetal environment factors. So this again gives us a clarity. So where neonatal infant and childhood growth following the metformin versus insulin treatment in GDM. So this analysis clearly showed that intrauterine exposure to metformin for GDM, the neonates were significantly smaller. So initially, if they're small, then they actually tended to be larger, right? So which means that the accelerated postnatal growth did happen, as was shown by the Barker hypothesis and all. And such pattern of initial low birth weight with the postnatal catch-up, so they are associated with the adverse long-term cardiometabolic outcomes. So this thing is not yet, again, what do we say? We are not yet sure about the outcomes with the metformin. That's why all the studies, they do suggest further studies examining longitudinal perinatal and childhood outcomes following the intrauterine metformin exposure. So which means this risk is always there in the back of the mind. So we are still not able to give a clear-cut answer saying metformin is 100% safe. So while we know that insulin definitely doesn't cross the placenta, so the risk of it altering the fetal environment is much lesser than what metformin would have. So now Shri is probably getting some clarity into it. So without confusing her more, just a slide about glyburide. So the other small player in the OAD team. So clearly it comes under FDA category C, but still widely used in US and other countries. Initially, why it was actually used in pregnancies, because it was assumed it doesn't cross the placenta because of its high protein binding. But the techniques which were actually used to see the levels in the child, it was not a good technique. So later on, multiple studies which utilize the LCMS technique showed placental transfer. That's why this is not advised as such. And it is linked to higher neonatal hypoglycemia, higher neonatal birth weight, higher maternal weight gain, as well as macrosomia. So glyburide as such is not much advised. So, but what do guidelines say? Let's see. So this is the ADA 2023. So again, it definitely stresses upon the lifestyle behavioral change as well as medical nutrition therapy, which has to be the basis or the initial foundation for GDM. In case they do not do well with that, then insulin has to be added to achieve the glycemic targets. And insulin is the preferred medication for treating hyperglycemia in gestational diabetes mellitus. So whereas metformin and glyburide should not be used as a first-line agent because both of them cross the placenta to fetus. And other agents, as such, we don't have the long-term safety data. This is what ADA 2023 has to tell us. And the previous ADA 2022 also, like 2020 also stands by this. So several randomized controlled trials, they have supported limited efficacy of metformin glyburide and not recommended as first-line agents because they are known to cross the placenta. And the ACOG also actually goes side by side as ADA does. So that is with metformin, there's a metformin can be a reasonable second choice, but it's very important to necessarily inform the risk of adverse events. of all to all the patients, like how Sherry came. It may not be wise to straight away say just because it's convenient to take tablets, you go ahead with metformin. But in case she is willing to take metformin, then we have to inform her about all the risk of adverse events, specifically about increasing prematurity, because multiple studies have shown that the gestational age could be lesser, and it could cross to the placenta, and the future risk, how it would affect the growth, is not yet clearly known. But then there are other guidelines, say FIGO, International Federation for Gynecology and Obstetrics. So they do give equal weightage to all the three drugs. That's insulin, glyburide, metformin are all safe and effective in treatment options during the second trimester of pregnancy. Blood glucose cannot be controlled by lifestyle changes alone. Similarly, when the NICE guideline says metformin is used if blood sugar target is not achieved within 1 to 2 weeks of MNT, and if patient is intolerant or cannot accept, then insulin is used. So there are some guidelines which still support the use of metformin as the initial choice. So take home message at the end of it would be medical nutrition therapy has to be told, and it's important in all. So if pharmacological agents are required, it's safer to start insulin. Better is a basal bolus regimen. And as such for metformin, we have to counsel that the long-term safety data is limited, because of which most of the patients as a part of concern to the child will definitely choose insulin. And the risk of maternal hyperglycemia, epigenetic changes, future diabetes, CVD risk has to be informed to patient and made an informed choice. Yeah, thank you so much.
Thank you, Dr. Akhila, for that excellent talk where you have really compared insulin with metformin, and I also have told about MIG and MIG tofu trials, and you have at the end of the talk, you have said it's insulin better than metformin. Now
Yes,
tell
sir.
me, in your practice, what would you do if a patient comes to you, means a gestational diabetes, and when you do it, the fasting is more than 120?
Yes, ma'am. Like if fasting is clearly more than 120, that is in the during that period, initial, ma'am, or in the later half missing?
No,
During
when
this
you
period.
actually you have detected a patient to have a gestational diabetes,
Yeah.
and when you do
Okay.
it, the fasting is 120. So what you will be your choice. Definitely, you are going to start them on insulin, not metformin. So can you
Yeah.
tell us instances when we can use metformin rather than insulin?
Okay. So in my practice, ma'am, almost none of my patients I have started on metformin, because I usually give them a choice of both, definitely. But I do tell them about the risk for the child. So in my practice, almost 100% of my patients are on insulin only. So, but maybe like I have seen when patients they don't agree at all for insulin because of the fear of pricks, or maybe almost like five months or more than that if we start in between, or initially like 7 months they have to take the prick, or maybe the cost also. If they are not willing, then I have seen that they have done well with metformin also. So maybe at the end of it, I wouldn't mind giving metformin, but most of my patients I would always counsel for insulin only, ma'am.
Yeah, then Dr. Akhila, can you tell our viewers how maximum dose of metformin that can be given in patients with gestational diabetes?
As such, the doses doesn't differ, ma'am. Like the general dosages, what they give a maximum of up to 2 grams. So that I have seen given in the practice also, because as such, the dosage wise, there may not be much difference. None of the studies have shown that this dose is bad or this dose is good. So the general dosage for metformin is what is being given in the pregnancy also.
Okay, so there are few questions in the chat box. The first one is, what about the designer molecules, insulins?
Yeah, so as such, we have seen that the RCTs are available for this thing, Lispro and Aspart. So these two have been used, like we can use either of them. There are some studies which have shown that the weight gain may be a little different with Aspart and Lispro. Like Lispro may lead to more weight gain and Aspart little less. But as such, the outcome is not different. But Glulysin, we have seen that not long RCTs are available. Most of them is just case reports here and there. And that's the reason Glulysin is placed a little lower. But generally, it's usually the Lispro and Aspart which is used.
Yeah, so there are a few more questions. Phenotype and anthropology data in native human versus human analog. Is there any study?
Uh, no, ma'am. Like because in general, insulins in general don't have a different outcome because they don't really cross the placenta. So that's why the phenotype studies, I'm not really aware if has been shown like a difference between the insulins.
Okay.
Final,
And
right?
what
Offspring. Yeah.
what was why the two anthropometric parameters were different in Adelaide Auckland cohort and the other one in
Okay.
McTaffur trial?
Yeah, so actually the recruitment time during the Adelaide as well as the Auckland, so they show a little difference. That is in the this Adelaide group, all the mothers, they had similar BMI, they were not varying much. And throughout the pregnancy, actually the metformin group had higher glycemia, uncontrolled glycemia. And even post-delivery, the babies, they did have a higher birth weight in Adelaide group. So whereas in the Auckland group, actually the mothers, they had a higher BMI initially, but then the offsprings were all having a similar birth weight. They didn't differ much. In fact, they were a little lower. So maybe the specifically the birth weight difference, that is the birth weight in the Adelaide group was a little higher, so whereas the birth weight in the Auckland group was a little lower. And this specifically the small for gestational age group, which is known to like have a postnatal catch up and then tend to be larger. So maybe that pattern, what is described by the Barker hypothesis, has made the difference between the Adelaide group and the Auckland group. So the initial recruitment and the offspring weight was actually differing between both the groups.
There's a question from Dr. Joe George. In a case of PCOD with or without IGT with infertility started on metformin pre-gestation, what is the current status as to whether to continue or shift to insulin once pregnancy is diagnosed?
Yes, sir. So even ADI 2023 talks about it. So that is definitely metformin has been shown to increase the ovulation chances as well as conception chances. So being used in PCOS, and once they conceive, then the safety has been even accepted by ADA guidelines also in the first trimester. And we have seen even the molecular pathogenesis wise, the transporters are not much developed in first trimester. So that's why the guidelines suggest maybe till the first trimester we can continue metformin, and after that it has to be stopped. And if still the GDM or the diabetes persists, it's wise to switch to insulin after the first trimester.
I think I will take one more question. There's a question from Dr. Harish Joshi. He says, premix BD and rapid at lunch, is it pretty poor compared to RRRL? The MRM TDS regime is not perfect, but is it more acceptable versus RRRL?
I think it differs from patient to patient, because I have seen patients doing well on premixed also. It's not always that bad. So specifically, I think it depends upon the glycemic levels. If initial glycemic control is very, very bad, say HbA1c is 9, 10. So in such cases, I would go for a 3 times rapid acting with the basal. Whereas in those patients who have a little slightly borderline elevation, but that's persisting throughout, so in them premixed also works well. So it's not wrong to give a try in those.
I think you are not audible.
Akhila, your voice is breaking.
Have needle phobia, so may not make much of a difference.
So thank you very much, Akhila, for this wonderful talk, and you have answered all the questions so nicely. On behalf of Rssdi Kerala chapter, I and Dr. Simi, thank you very much, and I thank all the organizing committee members for this wonderful CME. Thank you very much.
Thank you.
Thank you, Dr. Akhila, for clearing the confusion on which agent is to be used for gestational diabetes and making it very simple. Thank you, Anita Nambiar ma'am and Dr. Simi Kurian madam for chairing the session. So participant, Akhila, could you please stop sharing your screen? Dr. Akhila? Okay, thank you. Participants, please switch on your video and change your name to the registered name for the screenshot which is to be taken now, after which we will move on to the panel discussion. So please switch on your video, change your name to the registered name which you have used, and please wait for a few minutes.
Arjun, you can retype the name as Arjun and Balakrishnan. Dr. Balakrishnan.
Dr. Balakrishnan is not seen. Can you come closer to Dr. Arjun, Dr. Balakrishnan?
Oh, it's fine. Yeah.
We'll just wait for a few minutes. Thank you, participants and speakers and chairs. We apologize for the delay because we have more than 100 participants. It took some time. So we move on to the panel discussion. So the panel discussion, it is my privilege to introduce the eminent speakers we have in the field of diabetes today. The first moderator is Dr. P. Suresh Kumar, who is the State Secretary, Rssdi Kerala chapter. Sir is the Chief Physician and Diabetologist at Dr. Suresh Diab Care India, Calicut. He is a regional faculty for conducting the Public Health Foundation of India. Sir is also a PhD guide for Kerala University of Health Sciences. Sir has more than 40 research papers in peer-reviewed national and international journals. And he has held various key positions like President, Secretary, State Action Committee member in various organizations like IMA, Rssdi, IMA, MS, etc. The panelist, Dr. Vijay Kumar, who is a senior consultant at Medical Trust Hospital, Kulnada. Sir's area of interest include diabetic foot and epidemiology of diabetes. He is a current chairman for Rssdi Kerala chapter. He has also been the past president of Association of Physicians of India Kerala chapter between 2009 to 2011. And Sir has also received the BMJ Award for Excellence in Prevalence Health. He has extensive publications in various journals in the field of diabetes. The other panelist is Dr. Prashant Mapa, who is the consultant endocrinologist at EndoDiab Clinic, Kannur. Sir is also been the former associate professor at Kannur Medical College previously, and he has around 16 years of experience in the field of endocrinology. He was trained in DM endocrinology from the prestigious GS Medical College, KM, Mumbai, and he is trained in radioimmunoassay and clinical applications from BARC, Mumbai. Sir's area of interests include thyroid disorders and pediatric endocrinology. And also Dr. Akhila Bandarkar, who is the consultant endocrinologist at KS Hegde Medical Academy, Mangalore. I hand over to Dr. Suresh sir for the panel discussion.
Okay, thank you. Thank you, Arjun. Thanks a lot. Once again, My greetings to all. This is a wonderful morning. Actually, we had plenty of people here. And today for panel discussion, we have a very clinically relevant topic, the diabetes management, the traditional drugs and newer drugs. And as you all know, now several new drugs have been made available for the management of diabetes and also for its complications compared to the past. And newer papers have shown reduction in the incidence of complications or their progression in patients who are put on these newer drugs, some of these newer drugs. And at the same time, we do see several octogenarians having decades of diabetes on treatment with conventional drugs without much complications, still surviving. And the cost is way far too high compared to the traditional ones. And not many diabetic patients can sometimes afford them, the newer ones, the costlier ones, even if there is a clear additional extra benefit with the modern drugs. But anyway, even now here, insurance doesn't cover OP treatment for diabetes. And even if it does, vast majority are not even covered with such insurance, health insurance schemes. So affordability is a major issue. And doctors are actually put in a fix having to choose between the best drugs with evidence and the patient's comfort and affordability. If they prescribe the costlier drugs, sometimes many a times the doctors prescribe these costly medicines may lose their credentials, the credibility, and they may, patients or even relatives or somebody may label them as doing it for the purpose of earning money or who collude with the pharma companies, and for fear of that they may not prescribe the costly drugs even if it is indicated, clearly indicated. In this juncture, it is highly pertinent to discuss this topic and to learn from the experienced hands here. We have a panelist. We are 3 panelists representing probably, that is my guess, the conventional and the contemporary and the moderate views. We have 3 people. And I welcome Dr. G. Vijaykumar sir, Senior Consultant Physician Diabetologist. He's been already introduced and he's also the incumbent chairman of Rssdi Kerala State Chapter. And we have Dr. Prashant Mappa, who is a Senior Consultant Endocrinologist from the North Kerala. And again, now just heard Dr. Akhila, who is a Consultant Endocrinologist from the KSAGD Medical Academy, Mangalore. May I start with Dr. Vijaykumar sir, if you all permit? Sir, as a case scenario, I'm just asking you, suppose if you're presented with a patient who has high blood sugar and obesity, that is a conventional, the typical type of type 2 diabetes presenting to usual clinics. So what would be your choice of drugs, or how will you choose your drug and how will you intensify it? And I will place these questions to all the 3 panelists. So you can all answer in case if Vijaykumar sir has not covered a particular aspect, or if you have any specific area to project, please intervene, and you can, after Vijaykumar sir's finishing, you can also answer all the other 2 panelists. Please, Vijaykumar sir.
Good morning, everybody. Thank you, Dr. Suresh, for this question. But Dr. Suresh, before answering that question, actually, I have to have a background of today's regarding this topic, which is actually very close to my heart. As a person who has who belongs to the 1972 batch of MBBS, I had, or my generation had, the privilege or to use the very old drugs and also the moving on to the latest. We started when I started my practice in medicine. The drugs available for diabetes were even tolbutamide, chlorpropamide, which was available, and metformin, and also the bovine insulins. So from moving on from there, we have a host of array of drugs now, which actually I have learned from after my MD only. So this modern medicine, the beauty of modern medicine is that it's a continuing learning process. I am still actually today's discussion, I will be learning from my younger colleagues a lot more, which I did not know till today. That is a learning process of modern medicine. That is the beauty of modern medicine. Regarding actually the context where we are discussing is in Kerala, where the prevalence of diabetes is increasing, and my area of interest is epidemiology, which I have published a few papers in international journals. The latest being in 2017, where the prevalence of diabetes in rural Kerala, where I practice, is around 27%, which is the highest in India. And also our early paper 10 years back in 2007, the prevalence was only 14.6, and In 1972, the prevalence was only 2.3%. So from 2.3%, after a gap of 50 years, it has gone into 27% of type 2 of diabetes. So the cause of diabetes, the important factor which contribute to the increase in prevalence is the lifestyle, changing lifestyle. And without addressing that, there is no role for any drugs. So that is the background on which we have to start. So which is the most potent drug available for treatment? My answer will be lifestyle modification, because I have seen a lot of youngster patients, obese, techie people who coming with freshly detected diabetes at the age of 35 years. When we take a dietary history, they will be consuming around 4,000 calories of diet and doing no exercise. After lifestyle modification, the blood sugar has come down drastically. So that is the base on which there is no old drug or modern drug. Actually, I will show one slide as part of my share one slide as to answer that question. So this is an ADA-EASD guideline, which was published in 2017. That was the only thing which ADA and ESD has combined. So here, I am very fond of this slide, although the latest recommendations have come after that. This is here after metformin, they have put efficacy, high poor risk, weight gain, side effects, and cost, and they have categorized it. And all the 6 categories of drugs which are even available now, they are the only drugs available even now. They have placed it in single line, for which after metformin, you can choose any of them, depending on the other parameters, that sulfonylureas, thiazolidines, DPP-4 inhibitors, SGLT2, GLP-1 receptor agonists, and insulins. So all the 6 are placed in the single line, and you can choose anyone depending on the personal characteristics of the patient sitting in front of you. Which is the best? Which is the all these are good. I cannot say that we have to select a particular drug which is best for the patient sitting in front of you. That is the message which I want to convey. There are no older drugs or newer drugs. There are newer drugs. Newer drugs are coming up, but you have to place the older drugs also. You have to think of nothing is old. All these are used now. It has to be used judiciously. So that answers my part of my question, part of my answer. Regarding the specific question which Dr. Suresh has asked, I think being an obese patient, we have to depending on we have to get more details about his other things, whether he is exercising, whether he is what is his diet. We have to have a dietary recall, and of course, so as of today, if there are no contraindications, the first after diet, if the patient is not very much symptomatic or without any comorbidity or any obvious comorbidities or symptoms, I will definitely give a chance for diet modification and exercise and stress reduction before starting off any drug. Again, that depends on the initial blood sugar level. So the first medication which I will start for this patient will be metformin if there are no contraindications, and then titrate it to a moderate dose before going for other drugs. Over to Dr. Suresh.
You can stop sharing your screen, sir. Anyway, thank you very much, sir. I'll let the discussion itself lead us as the discussion evolves. So I have now specific questions to ask, but definitely a few more questions will be actually evolving out of the discussions. Now I will just ask others as well, like, what would be your choice in this thing? Dr. Prashant.
Thank you, Dr. Suresh. Actually, I mean, as sir mentioned, you know that obesity is not an emergency disease. So you always have to give a time for lifestyle modifications to have its effect. You do give him his time, and by 1 or 2 months, you know whether he's going to follow lifestyle modifications or he's not. Then definitely you will have to go to the second line agents. It depends upon the severity of obesity. As we all know, the most potent agents for weight loss, as far as diabetic armamentarium is concerned, is the GLP-1 agonists, and among them the dulaglutide and the semaglutide are the ones which by literature has shown the greatest weight lowering potency. But we know that both of them are injectable, both of them are costly. So as Sir mentioned, it's always individual, and the decision should be made in consultation with the patient. So we have to look at this. There may be patients who are not very affording, but their health concerns are more important for them. So in such cases, they may be able to, or they will definitely take these costly treatments. So discuss with them. I think the first choice, if they are willing and understand the situation, would be after lifestyle and metformin would be a GLP-1 agonist. But being injectable, it may not be suitable for everybody, or they may not be willing. The second choice after metformin would be a SGLT2 inhibitor, because dapagliflozin has gone off patent. It is not very costly, and maybe the second choice would be that.
SGLT2 inhibitors. Okay. So now we know what exactly. So now, where do you, is there any specific occasions where you can choose metformin and where you cannot? Like, sometimes you may not be able to use metformin in all patients, because you said lifestyle intervention, definitely. That is the foundation on which actually all the treatment has to progress or enhance. We have to titrate the treatment, other treatments, only after we fully satisfy and implement the lifestyle measures. If the patient is still not accepting or is not following the lifestyle measures, changes, then I think probably we have to go back and insist on them to adopt that lifestyle change before we advance with other medicines. That's what I think. And okay, now we have another drug. There are some people who start combination drugs, like when the patient comes, it depends on the blood sugar. Suppose if the blood sugar is high, suppose if this particular patient had obesity and his blood sugar was around 400 milligram random, like would you choose again the metformin thing, or a combination, or insulin, or something else? What is your suggestion? Dr. Akhila is there? I think I'll give her a
Yes,
shot.
sir. Yes, sir. So I think combination is definitely coming up now. So first thing is because we are spoiled for choice. There are too many combinations coming up, specifically in the Indian scenario, unlike the Western countries, because of lack of regulation maybe. But apart from that, the good part of it is that it reduces the pill burden. And in a specific situation like how you had just pointed out, so somebody who has a very high blood sugars also, I would definitely like to correlate that with HbA1c, because I don't know if it's just an acute such glycemic excursion or such a chronic thing is going on. So, but if HbA1c is also going in hand, showing a A1c level of more than 9%. So in such clear-cut situations, I think I would go for a combination right now, right in the beginning itself. And that's well supported by ADA also now. So in combination with metformin, definitely, because although it's an age-old drug, so but nothing can replace it, is my opinion. So in combination with metformin, including say the SGLT2 inhibitors, which have a good glycemic efficacy, and also some amount of weight loss also, which adds to the obesity issue, which I just pointed out, and maybe another drug, say like DPP4 inhibitors to begin with. So such a triple combination would be reasonable in such a patient. But if metformin is contraindicated in such situations, even if ANC is not very high, so something like 8 to 8.5 A1C, also I would like to consider a combination therapy if metformin is contraindicated for some indication.
Yeah, actually, yes, I think probably recommended combination drugs in case of high blood sugar, because the faster response, and also I think probably delay in treatment intensification. No, better response.
Can I have a word?
Please, sir.
I fully agree with both of them. After metformin, especially for this obese patient, definitely SGLT2 is an option. Of course, GLP-1 receptor agonist, I don't have much experience, but that definitely is there. SGLT2, and also if the patient cannot afford, affordability, if the affordability is a thing, actually now the price has reduced because SGLT2 and also DPP4 inhibitors, the price is less. Definitely they are the choice. Otherwise, you can consider if it is available, it is not there. Also in government supply is only sulfonylureas, glimepiride is available. Glimepiride can also be tried as the second choice.
But the only thing is that you have to be very cautious in titrating the dose. We have to start with a very small dose because hypoglycemia is definitely, although the efficacy of sulfonylurea is very high, the chance of hypoglycemia, which is a major risk. So you have to titrate it very judiciously. That is the only thing with sulfonylurea. Glimepiride and glycoside definitely have a role as the third line. But being an obese patient, I won't take it as the second drug. I will go with the SGLT2 or even DPP-4 inhibitors. Okay.
So, Dr. Suresh, I have one opinion, that is, see, when we are dealing with a new patient who has a sugar of 400 milligram, our concern is basically not obesity, but to reduce the glucotoxicity. So, to reduce this, we know that the newer drugs, whatever you tell, the newer drugs will reduce HbA1c by maximum of 1%. Unless, I mean, whatever said and done, sulfonylurea is a very powerful drug. And even if you look at the latest ADA guidelines 2023, now because of the cost concerns, it was a choice for patients who couldn't afford. But now even it is mentioned that in a patient with very high sugars, after insulin, there's just a line mentioned that sulfonylurea can also reduce the sugars, I mean, asymptomatic hyperglycemia, because we recommend insulin when the patient has a sugar of more than 300 or HbA1c more than 10. But they also mentioned that sulfonylurea can be used. I think a follow-up is what is essential. You start a sulfonylurea, bring down the sugars, and then you can start a newer agent to have the other benefits.
Okay.
Right. Okay. Now, I just ask you, the same patient, suppose if he had to come, he was coming with a high blood sugar and some osmotic symptoms, he is symptomatic. If he has got increased thirst or signs of dehydration or something like that, would you straight away start treating with the drugs or insulin, or will you try fluid replacement, correction of dehydration or hospitalization, or at least keeping him under observation for some time and giving some IV fluids to correct his osmolarity and then start drugs? What is your opinion? Then just wanted to, it's like common scenario.
Both should go simultaneously, because dehydration is part of hyperglycemia, but hyperglycemia needs to be treated. Definitely the first emergency is to correct the dehydration, which should be with IV fluids, especially in a patient who is in very severe hyperosmotic state. And then simultaneously, a patient who is very severely symptomatic, I think you have no other choice other than insulin. So we go on for dehydration and correct. Maybe do the HbA1c, see whether it is acute episode or it's a chronic thing, and then start on insulin. And patients with milder degrees of symptomatic hyperglycemia, I think, as I had mentioned, sulfonylureas are not a very bad choice.
Okay, I also agree. For the highly symptomatic patient also with complications, definitely the insulin is the choice. You have to start on insulin, bring down and blood sugar fast, and once that is over, you can switch over to OHS. That will be my line of thought.
Will you start insulin or okay then, Dr. Akhila, please.
Sir, I was just agreeing with the Prashant sir as well as Vijay sir. Definitely, that's the line of my management too.
Okay, like in that case, will you start insulin first, or will you give a fluid and correct the osmolarity and then start insulin? Which one will be your choice?
Both should go simultaneously. I will start insulin and also insulin infusions. Actually, it has to be started simultaneously.
Wouldn't the correction of osmolarity improve the insulin sensitivity and probably improve the response to treatment?
I think the others, I'm not very sure.
Definitely, sir. I mean, Suresh, I should definitely improve, but I don't know how much we can wait. I think you start on fluids, look at sugars, and do it simultaneously. But the first priority would be fluid replacement.
Can I just join here?
Yes.
I think probably we can just in a matter of one hour or 1.5 hours, we can give 2 to 3 liters of fluid, and the correct reasonable correction of dehydration can be made. I think that would be a good option, in my opinion.
Can I join here? Just clarify.
Sir, Bhargav sir. Sir, please. Sir.
Yes, because when you have hyperglycemia, there is an osmotic diuresis, there is a reduction of extracellular fluid volume, and when you correct with the normal saline at least 1.5 liter, your blood sugar value will come down to 300.
Exactly.
That is one. then you can start on depending on the insulin. You can go for either, usually basal bolus regimen will be better. After that, on discharge, you can continue with the insulin small dosage as well as you can combine with OHA. That is one thing. The other point I want to mention is at the time of diagnosis, what is your beta cell percentage in the body? It is about 40% is lost at the time of diagnosis, beta cell percentage. So the idea of treatment is beta cell preservation. So when you have a long duration of diabetes, beta cell percentage again is gone. So beta cell preservation is also important. There also insulin has got a role better than other drugs. That is also important. Thank you.
Okay. Thank you, sir. Thank you.
The
Sir.
most,
Okay.
but regarding one thing, sir, regarding the most important aspect in the management of type 2 diabetes actually is the patient has to continue the treatment. That is the most important thing. The adherence of the treatment which you prescribe. For a beginner, to begin with, if unless very much indicated, I think insulin will be a burden, which the adherence to insulin in the long run will not be very good. Actually, the adherence, you have to see that your prescription will be honored and will be continued. That is the most important thing. So you have to discuss with the patient before starting insulin. Beta cell preservation, of course, is good, but the most important thing is that adherence of the patient, because this is going to be a lifelong problem. So you have to discuss with the patient before starting insulin why you are putting on the patient of insulin, and if the background of the patient does not seem to be, the patient may not be continuing. I think we have options now. That's my opinion. Okay.
So actually, what I'm telling is, you are not going to prescribe insulin lifelong. You can tide out the crisis, and then at the time of discharge, you can go for metformin, renew this company. That is all. Okay. Because otherwise, there is a duty on the part of the doctor to convince the patient. Okay. The complications of diabetes. They can go in for ketoacidosis, they can go in for hyperosmolar state, they can go in for hypotension, all these things. So that has to be convinced, and we have to think that in diabetes management again, there is a place for insulin around 20 to 30%, just like OHA. There is a place for insulin. Okay.
Exactly. Actually, this would be a good opportunity when the patient is symptomatic and has got very high numbers. We will be scared, and that is the time when patient will better accept insulin. And probably, and if we can convince them that it's not going to be a lifelong thing and only for a short term, suppose we can start insulin and then we can switch him over to oral hypoglycemic agents, they will be willing. And another thing is that this experience will help us in again reintroducing insulin if we want later. Patient will already have had a experience with insulin, using insulin, and they know what insulin is like and how taking insulin is like. So that will be a better, I think, better side of starting insulin in initially when the blood sugar is very high. Okay, we'll move on from there. I think we have plenty of sulfonylurea, the conventional drug. Before going to the newer drugs, I'll just ask you, there are plenty of sulfonylureas available now. The older ones still stays from glibenclamide. The newer sulfonylureas are there, been very widely used. Will there be any choice of a specific sulfonylurea, like generally speaking, and not patient specific or something like that? Any choice for sulfonylureas, or where you place sulfonylurea in management diabetes? Anybody can take up the question.
If it is to be, actually, sulfonylureas, there's not much confusion now. The modern sulfonylureas, they claim, they named it like that, are the glimepiride and the glycoside, which is being used mostly. And which is the most potent sulfonylurea is still glibenclamide. Glypiride is the most potent sulfonylurea, which actually the side effect of hypoglycemia is a little more. And also glimepiride, maybe my choice will be a glimepiride. And also glycoside has got the excretion is basically through the liver. So an early renal dysfunction, glycoside can be used. So these are the two drugs which we use mostly now. But glyburide has also a role, because that is probably the most potent sulfonylurea available. Thank you. Thank you.
Others?
I think, as sir mentioned, these two drugs, as far as safety data is concerned, I mean, we know that because of the
glimepiride.
Conditioning, and meta-analysis of studies previously thought that it would increase the risk of cardiovascular disease. But as far as glibenclamide and glycoside are concerned, even in the latest ADA guidelines, it is neutral as far as cardiovascular risk is concerned. So I think they are the best agents to be used. But mind it, we have many patients, old patients who've been on a low dose of glibenclamide and very well controlled. So many a times we burn our hands when we think now it is better you don't use glibenclamide and you try to change their reports go haywire. So I think a patient who's already stably controlled with the older glibenclamide and does not have any cardiovascular risk factors, it is best safe to continue with them.
Yes, sir. So I think my experience is mostly with the modern sulfonylureas, because rightly the experience of Vijay sir and Prashant sir is vast. So most of my patients, even if they are old, and but if HbA1c is chronically high, like not a newly detected patient, so in such patients I don't see a harm of starting sulfonylureas even if they are old. But if it's a diabetes which is a new onset starting after say 65, 70, so in such cases I think I would not straight away go for sulfonylurea, even if it's a modern this thing, unless they have some renal issues, where I would prefer glycoside. But apart from that, I would go for a choice of either DPP-4 inhibitors or metformin. But if it's a chronic, long-standing high A1C, even in old, no harm in starting either glimepiride or glycoside modified release. Plus, in addition to what Prashant sir mentioned about the ischemic preconditioning, even weight gain is not a major issue with the modern sulfonylureas, apart from hypoglycemia advantage and cardiac advantage. Plus, the renal also quite a good safety. We don't have to do much of renal dose modification for glycoside. There are very few drugs which are available as such for renal patients. So I think that's a good advantage, taking both cost, affordability, and everything coming along.
Yeah, actually, the cardiovascular risk was been connected with the sulfonylurea in a study who looked at the tolbutamide and its CV risk in the beginning. I think probably that was established, and then later that was trying to be extrapolated to the other sulfonylurea. So there are also certain meta-analysis who had compared the head-to-head comparison who have been done with glibenclamide, glimepiride, glycoside, etc., etc. And it was found that those days, I think, remember some 10, 15 years back, there were some studies which says that glycoside is better, CV safe, whereas glimepiride is neutral, and glibenclamide is a little bit risky, something like that. Sort of things were the results were there. And that is the time when people were trying to look at the ischemic preconditioning mechanisms and all those things. Anyway, but the thing is, the glibenclamide is the strongest in terms of, I think, exhausting the beta cells, rather than the glycemic response. Also, for the initial few months, this is the strongest, but later on, it wins off, I think, the efficacy, and it may not last more than 2 years in the normal course of time, events. Then, in case if a patient stays well controlled on lower dosages of glibenclamide for more than 2 years, or say 5 years or 6 years, I think there is no reason to change that or stop that. That should be the way, rather than every patient who has been on glibenclamide has to be switched over to other newer sulfonylurea or something like that. That may be the reason. That's my personal opinion. Anyway, guidelines now say that suppose if the patient comes with established SCVD or high risk for SCVD or something like that, regardless of whether the patient is on metformin or not, you have to start some newer drugs like GLP-1 receptor agonist or SGLT2 inhibitors. What's your opinion, Dr. Akhila, please?
Yes, sir. There has been strong evidence also, lot of studies.
Yeah.
So yeah, sir. So a lot of studies actually now that we have dyslipidemia, and even with empagliflozin, there are good evidence. So taking all the evidence into consideration, and nowadays even cost is not a major concern when it comes to SGLT2 inhibitors. There are some of the brands which have really lowered their price. So I think we have to give an advantage to patient when it comes to the cardiovascular risk, leading that being one of the leading cause of death in diabetic patients. So right now we are not just treating sugar, so we have a major role in preventing their mortality, the cardiovascular mortality, also being a diabetologist or endocrinologist. I think that aspect has to be considered. So, but taken same time, I think the metformin also, unless contraindicated, I would definitely add on, not just one SGLT2 inhibitors, either in combination alone or in, with metformin, I would definitely start, because even that has its advantage when combined. So yes, sir.
Okay. After starting like SGLT inhibitors and metformin, will you stay put, or probably will you try to look at the other possible aspects of prevention of CVD risk, like statins, BP, or something like that? Will you start all of them together, or will you titrate it gradually, step by step?
It would be a gradual titration, so depending upon, first of all, he has come with some glycemic report. So the initial focus will be on reducing the blood sugars, because cardiovascular risk, we know it is helpful, but we don't know really how to assess if it's helping him or not. So based upon the studies only, we are relying. Main focus will be on the glycemic control, as well as other markers which would suggest a cardiovascular disease progression, like say microalbuminuria, or in case of males, erectile dysfunction. So all those things will be taken into consideration. So if the urine albumin is improving, so in such cases, I would not add further agents unless there is a requirement, and just keep it same. Or if there's further worsening, I would go on adding additional agents, be it taking glycemic focus or urine albumin, all those things. So yes.
Okay. Now we know that actually diabetics are having, or diabetic patients have plenty of people have what you call HFpEF, that is heart failure with preserved ejection fraction, like the otherwise called diastolic dysfunction, because almost around 80% of the type 2 diabetics, with some long duration of diabetes, have diastolic dysfunction, some degree of diastolic dysfunction, mostly grade 1 or grade 2, whatever, and that is called HFpEF. Will you consider that as an indication for starting GLP-1 receptor agonist or SGLT2 inhibitors in those cases? Anybody can take up the question.
I think, as you said, preserved ejection fraction, cardiac failure with the preserved ejection fraction is supposed to be a very common thing, which we don't usually do it for all our patients, because we don't, when only symptomatic, we go for the echo studies. But as you said, more than 60 or 70% will have some form of diastolic dysfunction. That doesn't make me to start on SGLT2 inhibitors for all my patients, because SGLT2 definitely has its own drawbacks also. Its complications like UTI, urinary tract infection, fungal infection, etc. And it's not a very potent drug also. But if a particular patient has got cardiac failure, definitely there should be a prescription, a drug as an SGLT2 inhibitor in his prescription. That's my view.
Okay. So, okay. Anyway, we have so many drugs to discuss. Like, what about we have incretin mimetics like DPP4 inhibitors. Plenty of them are there now. Which one is the best? Is there anything to choose between, or can Dr. Prashant initiate that discussion?
Yeah, and we do have many DPP4 inhibitors available in the market. As far as evidence for each is concerned, depending upon the area which it comes from, you have evidences. As far as glycemic lowering efficacy is concerned, I think most of them are almost equal. We do not have data from US regarding vildagliptin, but we have a lot of experience with enagliptin. So we know that it's almost equal as far as glycemic lowering efficacy is concerned. Now, how to choose a gliptin is dependent on other factors. Initially, the cost was a concern, and we used to go for the teneligliptin. Now, almost all the gliptins are in par. So then we have to choose, look for other factors. For example, the two gliptins which may have been associated probably with cardiac failure in the trials, one is saxagliptin, which is available in the market. So whenever a patient who has a high risk for heart failure comes, it's better to avoid that gliptin. Looking at renal concerns, there are gliptins which do not require dose adjustment during renal failure. The linagliptin and maybe the 10-gliptin. So in a patient who is in a borderline renal insufficiency, where we expect sometimes that the patient might go and the patient is not in regular follow-up, then maybe we'll choose such gliptin so that they do not need any dose adjustment as far as the renal functions are concerned. Similarly, if you're looking at liver diseases, so maybe the linagliptin is the most safe as far as liver diseases are concerned, and the recommendation tell that it's better to avoid vildagliptin if the the liver enzymes are more than 3 times elevated. So these are, I think, the few concerns with which we should choose a gliptin in a particular patient. But in generally, as far as the glycemic lowering efficacy is concerned, I think most of them are equal. I would like the opinion of other panelists in this regard.
I fully agree with Dr. Prashant in that aspect. Actually, there is not, apart from what he said, there is nothing to choose between them. The only thing is that after metformin, earlier I used to start with sulfonylurea because the cost of DPP-4 was very high. Now, if I go for a combination, and especially if I found that if the patient is elderly or the chance of hypoglycemia should be prevented, then I'll definitely go for a DPP-4 inhibitor after metformin. That's my take.
Okay, Dr. Akhila, there are there are a lot of controversies related to thiazolidinediones, especially thiazolidinedione that is available is pioglitazone now, and people are actually afraid to start pioglitazone because of these controversies. Even patients started questioning doctors who prescribe pioglitazone. Why you are prescribing this? Because it's been doctor to be causing problems. And where you place pioglitazone now? What's your opinion?
I think the thiazolidinediones have actually made a comeback in the market. Like the 2010, once rosiglitazone went out, I think probably the entire class was seen like a villain. But definitely the other advantages with that also went out. The other drugs like say pioglitazone and now even the lobeglitazone, they have their own advantages, and because of which it has a specific role even in the guidelines. Even ADA guidelines does not leave it out totally. So the pioglitazone in particular, I think apart from the insulin resistance area, has other advantages, specifically in NAFLD NASH. So that has made one area. Plus the cardiovascular thing, mainly in the heart failure, is the only area. The atherosclerotic disease definitely has an advantage with the pioglitazone. Multiple studies have shown that. And the same advantage will be carried over by the lobeglitazone also. Plus an additional thing is that it has a dual PPR alpha and gamma. So that is what they're claiming. So because of which the additional lipid lowering benefits could be there. And it has a better binding. So all these are molecular levels. So we are yet to see how much it will work out in the practical scenario. But definitely the advantages, say the ACVD risk, as well as NAFLD NASH, insulin resistance. So all this definitely has a role. And cost is also not much. So I definitely would consider in a younger patient who would come. Maybe an old patient is not a good person to start off with the pioglitazone, considering the risk. But a young patient with these areas of issues, the NAFLD as well as insulin resistance, I would combine it or maybe even give alone initially. So that's a possibility.
Okay, can I have a word? Regarding pioglitazone, actually, I will add as a third or fourth drug OHA to the existing regime. Only thing is that if the patient has got any evidence of cardiac failure, should not be given. And another thing is that if the metformin is contraindicated, as you said in the beginning, if pioglitazone definitely is an insulin sensitizer, pioglitazone can be given. For I will cite an example. One of my patients who has a film star, he was diagnosed to be diabetic, and he actually the first drug to be added was metformin. But when I suggested that there can be some weight gain, he wanted to put on some weight because he has to, in another film, he has to go for a fight with the hero. So I put him on pioglitazone in the beginning. And actually, the blood sugar came down and also his weight increased. So that is one indication for a lighter weight. I started on pioglitazone. Pioglitazone, of course, with all the so-called side effects after the rosiglitazone controversy, definitely is an add-on drug. Only thing is that you have to don't go for any combinations, because combinations maybe 15 milligram and three drug combinations, definitely the dose of pioglitazone will be very high. I usually give 7.5 or 15 milligram of pioglitazone as a third line, and I don't have for selected patients.
Yeah,
Okay,
you can
patients,
titrate it down to 7.5 milligram even for maintenance dosage, but maybe probably starting you have to start with 15 milligram for the response.
Prashant?
And pioglitazone as such, if you look at any drug, we first look at the contraindication for the same. So what are the problems with pioglitazone is, one is weight gain. Weight gain, probably both fluid as well as the redistribution of fat. Weight gain, because of fluid retention, it might not be helpful, and it may be detrimental in heart failure. So that is one concern we should not do. We should not give. Second is the bone health. So I think in postmenopausal women, when we are planning a long-term agent, pioglitazone would not be an ideal choice. But we have the other thing was the bladder cancer. I think that has been offset by the recent trials. That is not now a concern. The other things is you should look at the advantages of pioglitazone. So the advantages of pioglitazone, I don't think there is any durable. I mean, it's a very durable action. There are patients who've been on pioglitazone for a long time, and their sugars are well controlled. It's one of the most durable agents. Second thing is, as Dr. Akila mentioned, it's the only, I think, the drug other than GLP-1s which may be useful in patients with NAFLD where we have clinical data. So that is another concern. And now we have the IRIS trial, even in patients who do not have diabetes. It is probably in a patient who has had a recent ischemic stroke or ischemic event. It is helpful in preventing further episodes of cardiovascular events. So these are the advantages which we should take. We discuss with the patient, because even in a fat patient, it is a redistribution of fat and reduction of insulin resistance. So if the patient is not concerned of gaining 2 or 3 kgs of weight, and it's a good candidate, I think pioglitazone is a really good drug. I mean, after the other drugs, but it's a good drug at least for use in Indians.
And also there was some recommendation that pioglitazone has to be used for maximum 2 years, and then you have to reconsider or reassess the situation. What's your opinion?
I don't have any idea.
I don't think there is any recommendation like that.
No.
I have not come across any recommendation like that. Can be continued.
Okay, so another problem with thyroid sodium diabetes is actually osteoporosis and association with the fractures, especially in postmenopausal women, and probably problems with the like compounding the problems of osteoarthritis, etc., etc. So what would be your take on that?
So I think that is the reason why I think I do not use it in post-menopause and
or
who are at risk of osteoporosis, especially long term.
The patient may not be an ideal.
Pardon? You're not clear, Agila. Can you repeat?
No, sir. That's the reason I would suggest old patient may not be an ideal candidate, because we don't know what all issues can happen in them. So younger patient with these concerns would be the only one.
Yeah, and while the patient is on pioglitazone, especially higher dosage, if the patient comes with some history of fracture or something, you'll have to relook at it. That's what, because I had come across several patients who had minor traumas, ending with fractures, especially of the metatarsals, etc., etc. And we may not take it seriously as a drug-related issue. But then, if you relook at it, the drug regimen, then you will find maybe the patient was on pioglitazone for quite some time. So it's better. That's the right time to stop pioglitazone and switch over to some other drugs, I think. So anyway, we have several other drugs to discuss, but we have only 10 more minutes with us in hand. We have another newer drug that is in the market called imeglimin. It is a mitochondriotropic agent. Can you say something about that? Where will you use it? Have you had enough of experience with that? What's your take on that?
I've just used it in 3 patients, a very less experience, I would say. I'm yet to see the outcomes of it, but I had started in those patients who had metformin intolerance. So that was one area where I had used imeglimin, and even cost is not much actually. So it doesn't take too much to start off and maybe go ahead with a try, but I'm yet to see how it works in future.
Right.
I have not started it so far.
What about Prashant?
No, very few. I mean, it is not a dramatic drug that is going to reduce the sugars immediately, because just like SGLT, you know that within 1 or 2 weeks itself you see a difference. This does not. I have only few patients, but still to know the effects, because it's a novel mechanism of action. We do not know how it acts. But my patients, maybe they are wrongly selected. They usually come when they want to avoid insulin. As a last choice, we give another drug. So maybe we need more experience with the same. Anybody in the, I mean, Suresh yourself, is there any?
Yeah, no, exactly. The glycemic response is slow and also moderate in this case. Actually, if you want an immediate glycemic response, then it is better. It's not a good drug for trying. But suppose if there is a another interesting aspect which I had found is, like, there are a lot of patients who come with complaints of muscle cramps and all the sort of muscle maybe related to some mitochondrial associated myopathies, or maybe what I would say is it may not be absolutely the same thing, but still, in such cases, a few cases I had tried, I found some good response where the patient said better symptoms relief and all this. But I don't know whether that was really due to that. We need studies on that. Another secretagogue, that is the forgotten secretagogue, is actually the glinides, like the ripaglinide and nataglinide. So where will you use that? Are you still using it, or do you find any specific instances where you can use this particular drugs for the benefit of the audience?
Ripaglinide actually is a very short-acting sulfonylurea as a secretagogue. Actually, I am using it once in a while. The situation basically mainly is for controlling the postprandial hyperglycemia, and also in patients on early renal dysfunction. If you want to have sulfonylurea or a secretagogue, ripaglinide may be an ideal thing. These are the two situations where I have used. Still, I am using it as for controlling postprandial hyperglycemia.
Okay.
I think taking the cost into account may not be that much beneficial, because it's quite an expensive molecule which doesn't give a proportionate glycemic control, although the spikes, yes, but difficult to convince self as well as patient.
Yeah, okay. I agree that. We have other drugs also. We have acarbose.
Yeah, sometimes since it is much more powerful than acarbose, certain patients have very well controlled fasting and they have only this postprandial exercises. For such patients, I think it's not a bad drug. I've tried it in many patients and it does work, especially in North Malabar, where some people eat a lot of carbohydrates. That is one reason. I mean, one situation. And then as far as theory is concerned, nataglinide, because it's not metabolized in the liver, may be given in at least up to moderate liver insufficiency. Safely. So that might be a point of use for nataglinide. So the experience is very, very less for me.
Right. I think nataglinide is not been available these days. Mainly only ripaglinide is available.
Ripaglinide is available.
Only glinide available now. Nataglinide has almost stopped. Disappeared from the market. But anyway, having talked about acarbose, acarbose actually came to the market in 1997 or so in India, and ever since then, initially it was really costly, but response was not very good. There was no super glucose lowering response was not being seen with that. And the same way that the cost effectiveness was not there. There were a lot of problems, blotting and all this. But later came other alpha glucosidase inhibitors like voglibose. Now it is actually it is all over the market now, and there are plenty of combinations with the voglibose, sulfonylurea, metformin. So where will you use voglibose, or what is your view on voglibose and its efficacy and the use, contraindications, indications, etc. Prashant, can you say something?
Yeah, again, I use a lot of alpha glucosidase inhibitors, both voglibose as well as acarbose, and it's mostly for the postprandial spikes, because many of our patients, I feel that they have a higher postprandial glucose than the fasting glucose, probably because of the high content of carbohydrate meal. So what I try to do is we started at the main meal, so the meal with the highest carbohydrates, and definitely it has an effect. The side effects, which generally is perceived by many of the, what is mentioned in the books are not as frequent in, at least in my patients, so I've not found it as frequent. So these patients with postprandial hyperglycemia isolated means once you control your fasting with maybe sulfonylureas or the SGLT2 or the DPP4 and still you have an isolated postprandial, I use it. Then the another main situation which I use acarbose especially is in patients who have pre-lunge hypoglycemias, that is reactive hypoglycemias. In such cases, it's very, very useful. So such cases, we use most of them have this hypoglycemia coming nearly before lunch and when they start taking a lot of food. So giving a small dose of acarbose in the morning, 25 or 50 milligram, along with breakfast, reduces this effect.
I also fully agree with Dr. Prashant. Only thing is that I don't usually go for a combination. I use acarbose or as a single drug because theoretically it has to be taken along with the first bite of food. And the other drugs, metformin before, after food, and sulfonylureas before food, something like that. Anyway, this has to be given as a titrated, and the only use is for, as he said, controlling postprandial hyperglycemia. So it has to be given as a single drug, and just before, or with the first bite of food. And side effects, as he said, is not very much, very few gastric side effects only. And it's actually theoretically it's also a drug which is not absorbed, is definitely a very, very, very good proposition for diabetes management. I use a lot of acarbose.
Actually, please.
Regarding the timing of this drug, so we know that this thing, the glucose or the acarbose will be given to the first meal. First morsel of meal.
Right.
Then we always have a feeling that sulfonylurea should be given maybe some physicians prescribe it half an hour before food and metformin after food. But if you go into the literature of these drugs, it has to be given with a meal. It is independent of food intake. You should not take it when you're not taking a meal. But I think giving it along with a meal is safe, because if you look at the prescribing information of Amaryl, that is the glimepiride or diamacron, it's with meals. So initially I thought this is not a rational combination, but then when you give it immediately, you start eating food. I think it's an equal efficacy if you give metformin plus glimepiride plus glucose. That's I use it because the compliance is otherwise very difficult to have one before food, the one after food, and one with food. It's going to be very difficult. So I think it is a reasonable combination, and I found it to be effective.
Okay,
I will look into that, sir.
Yeah, okay. This is an interesting thing which I actually wanted to ask Prashant. Before that, I will just tell you another drug that has actually come and gone. Probably, I don't know whether it's still in the market. That was a dopamine 2 agonist, that the micronized bromocriptine. Is it still available, or are you still using, or there is any indications for that? Because it's been found to be having around 40% CV benefit. It's an excellent CV benefit for those who have been put on this thing for long term, more than 2 years. What is your opinion?
Don't have any experience.
Anybody?
It was one of
No,
the
sir.
one of the first drugs which are used after this CV trials became mandatory. That means they had one trial which showed good CV benefit. But as far as glycemic lowering efficacy is concerned, I've used it initially when it came out. I'm not aware if it is available now, but it has not been very efficacious. It is, in most of the patients. It doesn't seem to give any good glycemic control. That's my personal experience.
Okay, right. So how will you, suppose from oral drugs you switch over to insulin, or you'll have to proceed to insulin? Then how will you titrate the existing drugs when you are initiating insulin on a patient on oral hyperglycemic drugs, unsatisfactorily controlled type 2 diabetes? What are the how will you titrate the existing drugs? Like suppose the patient is on sulfonylurea, metformin, and all the, suppose if you have exhausted all the 3 or 4 oral drugs, and then now the patient is not having satisfactory control of blood sugar, and you want to initiate insulin, which one will you titrate, or how will you go about it?
The patient.
Yeah.
Aguila.
Sir, no. Please,
No,
please take it.
Okay, so when you're in an uncontrolled patient, when you're starting insulin, that means that the patient has already hyperglycemia. So even, I mean, the recommendation is that you should reduce the dose of sulfonylureas. But if you're just giving basal insulin, and you can always continue with the sulfonylureas, and then depending upon the sugars, the monitoring of sugars, you can then think of reducing the sulfonylureas. Especially when you're starting on branded insulin, it's better to reduce the dose of sulfonylureas. As far as metformin is concerned, I think the same dose can be continued. If you look at pioglitazone, because of the additional weight gain as well as the edema, I think the dose you should be cautionate. And when you are initiating an agent for better non-cardioglycemic benefits, for example, if you're initiating SGLT2 inhibitors, then definitely you will have to reduce the dose of insulin by starting on these drugs.
Okay. Before we wind up, actually, we'll be doing like an injustice if we don't mention about the oral semaglutide.
Suresh, you're muted.
So it's oral semaglutide. It is available now. It's costly. It's found to be very effective in not only glucose lowering but also in reducing body weight. Likewise, the combination GIP and GLP-1 like the dual agonist tirzepatide are all there. So a word about that. Like we can't close without talking on that. Akhila.
Yes, sir. So usually the first most important concern is only on the pocket. I think it's the cost. So apart from that, all that we hear about semaglutide is like good. So good effect on the heart, good effect on the appetite and the kidneys, renoprotective. So everything is good, but some amount of GI intolerance is definitely there.
You're interrupting.
Initial course, first 1 week or so now.
Yeah, you're audible. Yeah.
Okay, so I think the main issues are basically the GI intolerance and the cost. So, and we don't know really to tell to the patients until how long to take. So that is something which I always have a problem with. So until 3 months, somehow, yes, we can convince saying yes. But if they are very obese, so then the 3 months is definitely not enough. And once they stop it without adequate lifestyle modification, the rebound is expected for sure. And whatever they have spent will not come back. So a lot of these issues about uncertainty of how long to take and all those initial counseling becomes a problem. But if they're affordable and they are young patients who are well motivated, no, it's not a major problem, sir. I usually start it in the patients who are obese, maybe sometimes even newly detected diabetes, and in combination with metformin. Like if in the morning I give semaglutide, then maybe metformin I'll give in the evenings initially, not only semaglutide. So along with this, if the glycemic control is better, then gradually maybe I'll say like stop metformin if they're willing to continue semaglutide. But in those who are mainly for the glycemic benefit per se, when I'm starting semaglutide, obviously the patient will already be on multiple medications. So when I start this semaglutide, I would reduce, say, sulfonylureas or a bit because of high glycemic efficacy of semaglutide, and keep metformin and maybe eliminate DPP4 inhibitors, all those things. So generally a good outcome I've seen as of now, but until how long to continue is the issue.
Yeah, how bad is the side effect, GI side effect? Because I watched a few patients, like 5-6 patients, when after putting on these drugs because of severe nausea, vomiting, etc., intolerable side effects. Patient didn't.
Yes. I think at least they were able to tolerate 3 mg in my experience. So, but the moment I switch to 7 mg, they have major issues. Some patients have been on 3 mg for about 2 months, and they're even losing weight. May not be too much, but they're losing weight. They're motivated, less side effects. So, GI side effects is very unpredictable.
Okay.
Some patients have absolutely no problem. They're doing very well. So we don't know which patient will have problem with it. So
okay. Okay, that is okay. Like some patients have got severe GI intolerance, then we'll have to say bye to that patients, because patient will not come back to you for another option. Even I had patients who have been put on 3, started on 3, having severe problems, and they accused me of starting because basically they have a fear in mind looking at the cost factor. They think that is the strongest medicine, some sort of misunderstanding will be there in the mind, and that will be a problem. And another thing, one more just point I wanted to ask you, because so many of our diabetic patients will have some rheumatological problems like arthralgias, arthritis, and associated rheumatological problems, etc., etc. Commonly, we use HCQs or hydroxychloroquine for rheumatological problems as well. Now, HCQs is one of the drug that has been indicated for using diabetes as well. So, where will you place that? Prashant?
I have never used it as an anti-diabetic drug, and I don't have an experience.
What about Prashant?
Same too here. I don't have any experience. I've seen, I mean, many of the patients who do have diabetes as well as a rheumatological disease, they come, but I don't know how efficient it is. I'm sorry, I don't have any experience.
I've used in very few patients, sir, like those who have, say, borderline diabetes and with the rheumatological issues, some 200 mg hydroxychloroquine, they were doing well. But with uncontrolled diabetes and all, I have not kept it alone. But in such borderline diabetes, very few patients, I have used hydroxychloroquine.
Hello, excuse me for the interruption. We have passed 20 minutes extra.
We have 45 minutes. We started at 10:30. Now it is 11:22. Yeah, 7 minutes.
It's a very interesting. I expect that this will be prolonged.
We'll continue. Anyway, we have to. Everything have to come to an end. Now I think.
Comments from.
I want to add one point.
I'll just give Dr. Balachandran, from Kollam, sir, 30 seconds for him because he wants that specifically for some comments. Sir, are you there?
Are you audible?
Sir.
Yes, sir.
Okay. Thank you, Suresh.
Yes, sir.
Thanks, Vijay Kumar. Nice to see you, Prasad. So we have what is called as the transatlantic war. It's not the sulfonylureas which is very important. It is every sulfonylurea is good. In fact, the ischemic preconditioning occurring in glibenclamide, it's only a myth. It has been proved, but it is not. But still, just like beta blockers have come back, sulfonylureas will always also have a resurgence and will have got a major role to play because it has no side effects at all except hypoglycemia. It has no side effect. All this beta cell failure, all those things are all happens in really selected small group of patients. Number one, so sulfonylurea has got a place and it will come back. And second thing is about the ripaglidine, etaglidine, we use only for selected patients. All the drugs which you use, they see the side effects and select those drugs. See, for example, pioglitazone, you don't give for a person who has got a RBCs in the urine. You don't give for older patient who have got a high and people who have got eye problem where there is a maculopathy. So like that, you have to choose. Pioglitazone is an excellent drug, insulin sparing drug. It went out of the market and came back again. The same thing, glibenclamide is not available. It should come back. Third is, I don't use voglibose because I took voglibose and didn't take food for 2 days. So I stopped taking, I don't use voglibose. I don't find much importance as far as my patients are concerned because I've been practicing the last 50 years. Number 4, DPP4 inhibitor will stay back because there is now the main treatment is going to be only glucagon. Glucagon is going to be the drug. Now the lot of glucagon antagonism, glucagon receptor antagonist, glucagon ablations, reducing the population of glucagon. All the studies have come. 133,000 drugs have been under trial, but none of them have come to the phase 2 trial because mainly whenever middle with glucagon, they go in for stromal malignancy. That is one of the reasons why the glucagon was not taken. The only glucagon reducing drug we have is the GLP and DPP4 inhibitor. That also has proved to have a little bit of stromal malignancy, but selection of patients is very important in those cases. And the combination of SGLT2 works better because the side effects of SGLT2 taken care of by glucagon, and side effect of glucagon is taken care of by SGLT2 inhibitors, and the combination works better. Again, SGLT2, you don't use SGLT2 in patients who have got dehydration, or patients who have got side effects of like recurrent urinary infection. All those patients, you choose the patient. In acute condition, you don't use SGLT2 inhibitor. Choose the patient. It has gone out of the diabetologist's pocket and gone to the cardiologist and nephrologist, and they use much more because it has got more than the glycemic control. It has got a better this control. So all these drugs are being promoted by these two countries across the transatlantic. And that is how, suppose we take the sitagliptin is definitely a better drug compared to any of the gliptin, but again a transatlantic war. All these drugs have got an equal benefit effect, and still the sulfonylurea will stay back and it will come back because it has got the lead, doesn't produce any urinary infection, it doesn't produce bladder cancer, it doesn't produce, it doesn't break the bones, or it doesn't produce eye problem. None of those side effects of newer drugs have come, but we always have a fallacy for the newer drugs. That is one of the reasons why the discussion was very lively and very effective and very good. Thank you all.
Thank you, sir. Thank you very much for the summing up. And I also thank all the panelists for the active participation in the discussion. Thanks a lot, and over to Dr. Arjun.
Thank you, Suresh sir, Vijay sir, Prashant sir, and Dr. Akila for an excellent discussion. Now we move on to the next session, which is related to the panel discussion topic as well, emerging therapies in diabetes. And to speak on the topic, we have an eminent speaker, Dr. Vimal MV. Sir is a senior consultant and head of the department at Aster MIMS Kozhikode. Sir has done his DM in endocrinology from the prestigious KEM Institute. Sir has publications in index journals and lot of textbook chapters. He was organizing secretary for Mendos in 2017 as well as 2018. His particular areas of interest include diabetes, thyroid, and pituitary. I now hand over to the chairpersons, Dr. P.V. Bhargavan sir from Calicut and Dr. Shaji A from Perindalmanna to chair the session.
I am Dr. Bhargavan from Calicut. Thank you very much for the opportunity given to me for chairing this important session on, especially on emerging therapy in diabetes mellitus by none other than the.
Can you unmute your video, sir? And unmute your video as well, sir. Bhargavan, sir.
Okay. Okay. This topic will be presented by Dr. Vimal, Senior Consultant Endocrinologist of Aster MIMS at Calicut. And to introduce the topic, we have listened to a very grand discussion on all anti-diabetic agents. And they have also suggested various indications and contraindications. When you see a patient with diabetes, what is most important is you have to ask the hereditary nature, the family history, and also you have to insist on the management, especially the diet and exercise, because 40% of the patient, especially with all the other genetic or non-genetic and the other factors, they can have control of hyperglycemia, especially initial 5 years of time or 3 years of time, if you concentrate on diet and exercise. That is very important. Then they may require 20 to 30% of cases may require around OHA or any of the drugs that is available. And lastly, when the stage of beta cell failure occurs, they definitely require insulin. So the point is, one should not hesitate when there is a total beta cell failure. When you see a diabetic patient after 10 or 15 years, the HbA1c is more than 8.5 or 9.5 and various microvascular and macrovascular complications. Still, you should not be hesitant to start on insulin because in those stages, they require insulin. One problem with especially the glycosylglamide and other things is in an elderly patient, they may produce a profound hyperglycemia, especially because of the association of other comorbid conditions, CKD, and because in an elderly patient, the comorbid condition, vascular complications are high, and they may have a prolonged hypoglycemia. Similarly, some of these patients, especially the glycosylglamide, some of these drugs may produce maybe the route of excretion may be from the liver or sometimes from the kidney, and some of the glycosylglamide may be useful in kidney disease, especially glycoside, etc. We have a battery of drugs, especially belonging to sulfonylurea, which is highlighted, non-sulfonylurea, dipeptidyl peptidase inhibitors, the oral GLP-1. You have the drugs reduce the insulin resistance, especially bioguanide, thiazolidinedione, and drugs acting on carbohydrate absorption, alpha glucosidase inhibitors, drugs acting on renal reabsorption and Vascular metabolic factors are controlled with SGLT2 inhibitors, centrally acting drugs, bromocriptine, etc. And the latest drug, that oral semaglutide. Now the topic is actually emerging therapies. Probably the speaker will be highlighting on SGLT2 inhibitors, oral semaglutide, and other newer drugs which is coming. One request is, when you have so many drugs in the armamentarium, the patient sitting before you is the person who decides the treatment apart from the doctor. You have to individualize the treatment. If the age of the patient is very elderly, don't go for a strict control according to the ADA guidelines. You may have a partial control. An HbA1c or 8 or 9 sometimes is acceptable. When you have a young patient, you go everything possible, that is to preserve the beta cell function is your aim. At the same time, you have to control these things to prevent the vascular complications. Over to Dr. Vimal, who is a very famous endocrinologist in North Malabar as well as Kerala, for delivering his address on emerging therapy in diabetes mellitus. Thank you.
Good morning. At the outset, I'm extremely grateful to Rssdi Kerala team for inviting me to discuss something about emerging therapies in diabetes. I'm also grateful to Bhargavan sir for his kind words of introduction. I assume that I'm visible and audible and my slides are visible.
Yes, sir. Slides are open.
Yeah. So I think I will just talk about 5 molecules and one technology in diabetes development. I may not be placing these molecules, where to start these molecules and everything I may not be discussing. I will be just telling the newer developments. I am just giving an introduction to the newer developments in the diabetes mellitus treatment armamentarium. So my disclosures, no conflicts of interest. I am extremely grateful to Dr. Matthew John, Senior Consultant Endocrinologist, Providence Endocrine and Diabetes Specialty Center, Thiruvananthapuram, for helping with slides, and also Dr. Pradosh Gangadhar. Obesity and diabetes. What are the newer developments? So I'll be talking about semaglutide and tirzepatide, as has been already discussed by Suresh Kumar sir. Semaglutide is a GLP-1 receptor agonist. We all know that it is a GLP-1 receptor agonist, and we have been using it for some patients. Like oral semaglutide we have been using, which is known as Rybelsus. Even I am having an experience of around 30 patients on oral semaglutide. I found that it's extremely useful, especially in obese diabetic patients. But we are not having the availability of injectable semaglutide. The 1 milligram weekly injectable semaglutide is known as Ozempic, and 2.4 milligram per week is known as Wegovy, which is going to be launched within 1 or 2 years in Indian market. The release to the Indian market is getting delayed, mainly due to the mismatch between demand and supply. It is a big hit the Western countries, and it is not at all available. The raw material is not at all available, and that's why the release is getting delayed, because we know the Western diabetics are having obesity, and especially US population are having obesity as well as diabetes mellitus. And this molecule is injectable semaglutide has been a big hit in the Western markets. That's why it's the release is getting delayed. Semaglutide for weight loss, basically the significant weight reduction we get with subcutaneous semaglutide, 2.4 milligram per week. This is also known as Wegovy. And we know the chief adverse effects are mainly gastrointestinal, like nausea, vomiting, and occasional cholelithiasis. These are the side effects of injectable semaglutide. And weight loss with semaglutide has been pretty impressive. We can see here the STEP program, which is with the injectable semaglutide 2.4 milligram. And we can see that there is a 15% weight reduction with injectable semaglutide. And so if a person is weighing around 80 kg, after starting semaglutide, he will be weighing around 64 or 65 kg. That's a good 65 or 66 kg. That's a good weight reduction. It's around 15% weight loss you can get with the injectable semaglutide, and it's getting sustained for a longer period of time. You can see in the slide that it's getting sustained for around 68 weeks after initiating semaglutide. So it's a extremely good data as far as obesity is concerned for injectable semaglutide. What are the indications for injectable semaglutide? The drug is indicated for chronic weight management in patients with a body mass index of 27 kilogram per meter square or greater, who has at least one weight-related ailment like an osteoarthritis or obstructive sleep apnea or something like that, or a patient with a BMI of 30 kg per meter or greater. So these are the indications. And I am just moving because I'm just brushing through the newer developments. I am just moving to the second drug, which is tirzepatide. I think it has been already mentioned. It's a dual GLP-1 receptor agonist formulation This is the synthetic peptide containing 39 amino acids based on the native GLP-1 sequence. And we know, I think this slide has been discussed again and again. We know that the GLP-1 receptor agonism, we can see in the central nervous system, it acts to increase the satiety, decrease food intake, increase nausea, and decrease body weight. In the pancreas, GLP-1 receptor agonism leads to increasing insulin, decreasing glucagon. And I think just now we have discussion about glucagon, the effect of glucagon. So we know decrease glucagon spike, it has been, and we know it can reduce hyperglycemia and it can improve the insulin sensitivity as well. In the central nervous system, GIP does decrease food intake and decrease the nausea as well. So GLP-1 increases nausea and GIP decreases nausea. So that side effect might be partly balanced if you combine GLP-1 with GIP. In the pancreas, it increases both insulin as well as glucagon. Probably it may act in a counter-regulative manner to in the case of hypoglycemias. Subcutaneous bite adipose tissue, it increases insulin sensitivity, it increases lipid buffering. Again, as well, which is one of the important components of metabolic syndrome. And the skeletal muscle, GLP-1 receptor agonism improves insulin sensitivity. So if you see the mechanisms, we can see that it is extremely useful for the management of diabetes mellitus, because there is GLP-1 receptor agonism as well as GIP receptor agonism. So GLP-1 and glucose-dependent insulinotropic peptide is a 30 amino acid peptide synthesized in the L cells of the intestine. I think all of you know. GLP-1 receptor exposed in the pancreas, GI tract, kidney, heart, and brain. GIP is a 4 amino acid peptide produced by the K cells of the intestine, mainly located in the duodenum and proximal jejunum. Receptor is exposed in the beta cells, adipose tissue, as well as in the brain. So this is the A1C goals, the meeting A1C goals with tirzepatide. You can see here the change in glycosylate hemoglobin from baseline. You can see tirzepatide 5 milligram, 10 milligram, 50 milligram, and semaglutide 1 milligram. So you can definitely see that it is extremely superior to semaglutide in the HbA1c reduction. You can see the 2.3% reduction in the HbA1c, and you can see here the comparison. The 50 milligram semaglutide being shown here. Patients who met HbA1c targets of less than 7, you can see maximum with 50 milligram of tirzepatide, and also 6.5 also maximum 50 milligram tirzepatide when compared to even semaglutide. And even some people are getting HbA1c of less than 5.7 with the use of this drug. And the fasting glucose levels are also significantly coming down. This is based on the Sermon trial with the tirzepatide. And weight loss with tirzepatide again, we have seen the glycemic data in the previous slide, but here again the weight loss data with tirzepatide is so much impressive. So we can see that again, even compared to the oral semaglutide, the weight loss data is superior to semaglutide, and there is around 13 kg weight loss with the use of tirzepatide as per Sermon trial. So what are the advantages of tirzepatide? There's a significant weight loss, significant reduction in the HbA1c to the tune of around 2.3%, which is much higher than other oral antidiabetic drugs like even sulfonylurea or gliptin. It's significantly higher. Favorable effects on the lipids and blood pressure. We know that it acts on the atherosclerotic, and you can even have a CV benefit. These are the drugs which have shown to have significant CV benefits. Adverse effects profile comparable to injectable GLP-1 receptor agonists, like semaglutide. Probably the nausea part may be less if you are using tirzepatide. We don't have this molecule available in the market. And this is the Sermon 1 trial again for in obesity, and we can see that in this trial around 20 kg weight loss has been there with the use of tirzepatide. So it was published in 2022. So we can see that when compared to placebo, there is a significant weight reduction that is happening with tirzepatide, and it will be one of the most useful drugs for patient with diabetes and obesity once it is getting released to Indian market. As of now, we don't have the availability of this drug. Probably we may be getting this drug within next 1 or 2 years. That is what we are expecting. And the dose of tirzepatide, we can see that we start slowly and escalate slowly. So we start 2.5 milligram once weekly for starting the experience, so that the patient get acclimatized to the drug, and then continue the experience of 5 milligram once weekly for the month 2, then 7.5 milligram once weekly, 10 milligram once weekly, 12.5, and ultimately 15 milligram once weekly the person is tolerating. So we know that from our experience, our patients may not be tolerating 50 milligram for sure. That's what I expect. So we may probably have having to give a dose of around 10 milligram per weekly. That may be our dose of tirzepatide. These are my speculations only, but we don't know. We have to wait and see how tirzepatide will act in Indian population. Now I will switch out the third part of my talk, which is once weekly insulin that is known as icodec. So we know icodec has a strong and reversible albumin binding properties along with reduced insulin receptor binding affinity. Inactive circulating albumin bound depot from which icodec is slowly and consistently released, and the Tmax is 16 hours and T half is 1 week. So if you're injecting today is Sunday of 17th of September, the next dose is to be injected only on 24th of September. So after 1 week, we can inject this insulin, and that is the advantage. This is a basal kind of insulin, and the duration of action is extremely prolonged. We know because of its albumin and the fatty acid chains, just like detimir. It has got an albumin binding, which is a reversible albumin binding property, and now with reduced insulin, the action gets protracted. So, that's how this insulin is developed, and this is one of the latest articles around 3 months back. We know this article has been published. Weekly icodec versus daily glargine in type 2 diabetes mellitus without previous insulin. It has been shown that glycemic control was significantly superior with once weekly insulin icodec than with once daily insulin glargine U100. And the advantage is that even the hypoglycemia level 2 and level 3 hypoglycemia was found to be similar or even slightly less than that of glargine. That is the advantage of weekly icodec. And you can see the data here, the efficacy and safety of icodec over 52 weeks. This is glargine U100 and this icodec, and it's definitely non-inferior to glargine U100 at least. As far as HbA1c reduction is concerned, and the continuous glucose monitor have been done, and you can see the time below range, which is extremely important in patients with the diabetes mellitus. You can see that icodec is almost comparable to glargine U100 as far as the time below range is concerned, and the achievement of glycated hemoglobin level less than 7 has been even better for icodec when compared to glargine U100. And this is the latest data, and the data even 3 years back in 2020 data also shows that icodec is superior to glargine as far as HbA1c reduction is concerned. You can see the baseline HbA1c of around 8, which is coming down to 6.610 with icodec and 6.87 with glargine. And you can see the persons who are meeting the HbA1c targets are more with the icodec when compared to glargine. So this is regarding the third part of my talk, that is icodec. And I'm going to the fourth part, which is, I think, just been already discussed, but I will just brush upon the renal therapeutics with the finerenone. So we know there is one aspect which has not been tackled by the usual renoprotective drugs, that is inflammation and fibrosis. The drugs tackling the hemodynamic abnormalities in diabetic kidney disease like ACE inhibitors or IRBs, thiazide diuretics or dipyridamole calcium channel blockers and SGLT inhibitors. And also we have drugs which produce metabolic control as well as glycemic control and renal protection like gliflozin, GLP-1 agonists or metformin. And we don't have any drugs to tackle the inflammation fibrosis, which is one of the reasons for the renal damage in diabetic kidney disease. So finerenone is a novel non-steroidal selective mineralocorticoid antagonist, which is a bulky non-steroidal molecule. Unique structure results in selective and potent interaction with the mitochondrial receptor, with the mineralocorticoid receptor and regulation of gene expression, and exhibits anti-fibrotic and anti-inflammatory effects. So this is what finerenone does. It is a non-steroidal selective mineralocorticoid receptor antagonist. And we know the Fidelio and Figaro trials. Fidelio trial was done in stage 3 and 4 CKD, and Figaro trial was done in stage 1 to 2 CKD. The primary endpoint in Fidelio trial was decrease in the CKD progression by around 20% reduction in the CKD endpoint. You can see even the confidence interval is between 0.73 to 0.93, which shows the superiority of finerenone compared to the placebo. So again, reduction in the CV mortality and morbidity. And in Figaro, which is early CKD, it was tried, and even it was seen that there's a decrease in CV mortality and morbidity and reduction in the CKD progression, which may not be statistically significant. And one of the reassuring things regarding the use of finerenone has been the chance of hyperkalemia was not that significant, and this drug is to be used over and above gliflozins as well as a maximally tolerated dose of ARBs. That's where we place this molecule, and definitely we know there is a definite subset of patients who progress with albuminuria or CKD despite having been on ARBs or gliflozins. We have seen so many of those kind of patients, and this might be a good option for those patients who are already on ARBs and glucose, but still having progression of renal disease. And it is costly, we know, but still for the renal production, that might be worth spending that much amount for finerenone. And the usual dose of starting finerenone is, if the GFR is more than 60, it is 20 milligram per day. If it's between 25 and 60, it is 10 milligram per day. Less than 25 is not recommended. So that's the approval based on DCG recommendations. So diabetic kidney disease, I think this is the last slide on finerenone. eGFR and urine ACR is there. SGLT inhibitor is preferred. First line if GFR is more than 20. GLP-1 receptor agonist even if GFR is less than 20. And finerenone if GFR is 25. So I just put the GFR here based on latest trials. SGLT inhibitor, even the latest trials have included even GFR more than 20. So this is how we stand as far as diabetic kidney disease is concerned. So now I think I will just move to another area in which I am not an expert. I have not used this drug as well, which is finerenone, which acts by mitochondrial modulation. I think Dr. Suresh Kumar sir was telling about the mitochondrial bioenergetics and mitochondrial dysfunction, which will be common in our population. We don't have many studies regarding the mitochondrial dysfunction in Indian population. So mitochondrial dysfunction might be another important aspect, a pathophysiological process which we are not gone into the depths of that. So mitochondrial dysfunction is a common feature of type 2 diabetes mellitus pathology that contributes to both beta cell defects and insulin resistance. So it is said that in type 2 diabetes mellitus, there is some kind of a deficient oxidative phosphorylation with reduced ATP generation. It reduces insulin secretion because of reduced ATP. That is one thing. That's a part of mitochondrial dysfunction. Second is, it is said that when there is mitochondrial dysfunction, there is excessive reactive oxygen species formation, ROS formation. Then there is MPTP, there is mitochondrial permeability transition for opening and apoptosis of cells, including beta cells. And there is increasing insulin resistance as well. So what imiglumin does, theoretically, I don't know the practical aspects, but theoretically what it does, it inhibits the complex 1, reduces reverse electron transport from complex 2 to complex 1, and thus reduce formation of reactive oxygen. Reactive oxygen species, we know, it's one of the important reason for damage. The free radical theory, we know, damage and oxidative stress theory, know. So the oxidative stress is one of the important mediators of inflammation as well. So what happens is that from C2 to C1 reduces reverse electron transport from complex 2 to complex 1. And that is beneficial to reduce the reactive oxygen species and also to increase the AMP kinase. We know this similar to mechanism of action of metformin. And there is restoration of complex 3 by imiglumin that prevents MPTP and lessens apoptosis of beta cells and increase ATP generation, improves insulin secretion, acts through salivary pathway and increase. I think these are only theoretical points, but I think this part is very important. It enhances insulin secretion as well as enhances insulin action. I think we'll focus on that. So in the liver, it reduces excessive gluconeogenesis and decreases steatosis. That is extremely important because nowadays we are seeing many patients with the NAFLD or nowadays we call it as MASLD as well. Muscle increases insulin signaling by increase the GLUT4 translocators, stimulates glucose uptake in the muscle. And also in the pancreatic beta cells, it increases calcium mobilization, increases insulin secretion as well. So on the contrary to metformin, metformin usually doesn't increase the insulin secretion. Apart from the GLP-1 stimulating action of metformin, metformin can induce GLP-1 genes. That is there, but still, directly metformin doesn't lead to any increase in the insulin secretion. But here, imiglumin improves the insulin secretion as well. It's an insulin secretagogue as well as insulin sensitizer. So definitely there are multiple facets of action of imiglumin. On the liver, it decreases gluconeogenesis, increases glucose utilization. In the muscle, it increases glucose utilization. In the pancreatic tissue, it increases insulin secretion, decreases beta cell apoptosis. So there is decreasing insulin resistance and increasing insulin secretion with the imiglumin, which makes it an attractive molecule, at least theoretically. So even I don't have any much practical experience with the use of this molecule, but if you go as per the studies, the glycemic control is not that much robust. It is around to the tune of around 0.5 to 0.8%. Probably you might use this molecule in patients who are having insulin resistance, and the place in the armamentarium we have not properly positioned. We don't know. Because it's still in the evolving stage, we don't know where to position this molecule. But still, in patients who are having insulin resistance and in patients who are not willing for insulin after 3 or 4 drugs, probably you can think of this drug. And it is relatively safe when the GE side effects are supposed to be less than that of metformin, and it improves the beta cell as well as skeletal muscle energetics. Cardiac energetics is also improved along with glyphosins. There is a shift in the cardiac energetics. Insulin secretions improve. There is an advantage when compared to metformin. Inhibition of hepatic neogenesis there. Insulin sensitivity is also improved by this class of drugs. So this is how we compare immunoglobulin, gliptins, and glyphosins. And probably after 3 or 4 years, we will be hearing more about immunoglobulin and the place, even the ADA recommendations, probably it might come up. As of now, these are the things that we know that I wanted to share with you. And now I will move to the last part of my discussion, which is artificial intelligence in diabetes. Actually, it's not a molecule. It's kind of a technique which has evolved over time. So this is mainly for type 1 diabetes mellitus, where we have progress regarding the use of insulin pump therapy. So we know we had sensor augmented pumps in the past. CGM integrated pump was there, which was integrated with CGM. And when the sugar values go down, it automatically switches down, so that the problem doesn't happen. Then came the hypoglycemia doesn't happen, it's getting alerted. Then came the overnight closed loop system, automatically determines the insulin infusion rate during nighttime, because we are so much worried about nocturnal hypoglycemia. So we should get an idea about nocturnal hypoglycemia. So overnight closed loop system was there. Then hybrid closed loop system is there, automatically determines basal insulin infusion rate all day with user initiated mealtime bolus, improved all day time in range and time below range, because we are concerned about time below range in the CGM. And advanced hybrid closed loop system, which is almost like an artificial pancreas. It's kind of a closed loop, because the patient need not be aware always. Once the patient gets used, or the insulin pump gets used to the patient, so probably the pump itself can lead to correctional bolus function. So what the pump does is it gives a continuous basal insulin, and the patient has to just dial the amount of carbohydrate that the patient has taken, so that the bolus dose is given. And if by some mistake, if the patient has not dialed how much dose is to be given, or how much the carbohydrate, the machine itself will inject insulin. So that's the advantage of advanced hybrid closed loop system, so that the patient almost forgets that he's having type 1 diabetes mellitus. So this is extremely useful for type 1 diabetes mellitus patients who are having chronic who are having diabetes mellitus. So he can just forget. He can lead almost like a normal life if he's on this kind of artificial pancreas. It's a Minimate 780G system. How does it work altogether? There's a Minimate 780G pump, which is linked to a transmitter, and also a meter is there, which is connected to computer. I am not going to the details. And then mobile smartphone app is there, where we get the data as well. And it can be even the mobile of the caregiver. So advantages. And this pump of insulin pump has even improved the glycemic parameters. The time in range has been increased to more than 70%, around 75%. So I'm having 3 patients on this insulin pump, and I've been extremely happy with this insulin pump. And this is one of the patients, Mr. B, who is my patient, who had significant glycemic fluctuations, like the patient sugar values was going between 30 to 300 or even 500. One day he goes to DK, second day he goes to severe hypoglycemia. Those kind of brittle diabetes mellitus patients was Mr. B. So I put the patient on this kind of 780G insulin pump, and you can see the time in range of around 75%, and you can see the time below range is 0. So that is the beauty. That's the attraction of this kind of insulin pump. The time below range is extremely less, so that there is no hypoglycemia that is happening to this patient. And it's prohibitively costly, I know, but it improves the quality of life of patient with type 1 diabetes mellitus like anything. So that's the advantage and it is done through artificial intelligence, and this is one of the biggest contribution of artificial intelligence to diabetes armamentarium. So that is where we stand in the newer artificial pancreas. So to revise what all is that I told you, first is regarding obesity and diabetes mellitus. I told you regarding semaglutide, especially oral we are having. So I told you about injectable semaglutide like Ozempic or Wegovy. Wegovy showing the results of significant weight loss. And again, I told you regarding tirzepatide, which is a GLP-1 GLP co-formulation, which showed significant glycemic benefits as well as weight loss benefits to the tune of around 20 kg. And then I told you about icodec, which is a once weekly insulin. Which can be given. So what's the start? I've just tell you what's the starting dose of icodec. It is 70 units per week. So that is the usual starting dose, and you increase or decrease by around 10 or 20 units. That's how we change the dose of icodec. Just for the information, we are not having the molecule, but still This is regarding ICODED. Third, we told about finerenone, which may definitely be a benefit for the patients who are having CKD or diabetic kidney disease. That is the only indication for finerenone is diabetic kidney disease who are already on glucosis or ARBs, maximal tolerance of ARBs or AC inhibitors, and it will provide another 15 to 20% reduction in the albuminuria or CKD progression risk is there. So definitely finerenone might be useful in the diabetic kidney disease. And then we talked about mitochondrial dysfunction and imiglamin, which may be a promising molecule, though I don't have any personal experience. It might be a promising molecule in the future, though it is seen that the HbA1c reduction is not that robust, which might be evolving over time. And then we told about artificial intelligence in type 1 diabetes mellitus especially, where we are having the 780G system of Minimed 780G system. It's almost like an artificial pancreas where the patient can forget about his illness of type 1 diabetes mellitus. So once again, I thank you all for your patient listening. Thank you so much. Over to our organizers. Thank you.
Thank you, Dr. Vimal. As usual, you have very precisely touch upon all the newer emerging therapies in diabetes. We know there is no single therapy for diabetes. We have to think of many molecules, and new therapies will be emerging in the future. And you have talked about AI in diabetic therapy. It's very good, excellent. Thank you, Vimal. And I think we are running short of time, and we won't be taking any questions. If any questions is there, you can share in the chat box, and Dr. Vimal will be answering it. Thank you. Is it okay?
Thank you so much. Thank you. Thank you, Shaji sir, and thank you, Bhargavan sir, once again, and also thanks all the organizers like Dr. Arjun, Dr. Joe, and Dr. Prashant, and even Suresh Kumar sir, as well as Vijay Kumar sir, and all the and also Balakrishna Malliod sir for inviting me to discuss something about this topic. Thank you.
Thank you, Vimal, for the wonderful talk. Thank you.
Yes, thanks.
Thank you, Vimal sir, for your insights into the usage of these newer molecules and giving us a brief overview. Thank you, Bhargavan sir and Shaji sir, for chairing the session. We move on to the next session, management of inpatient hyperglycemia, how to treat and how much to treat. The speaker needs no introduction in this group. Let me invite Dr. R. Chandni ma'am, who's a professor of medicine and HOD of emergency medicine at Government Medical College, Kozhikode. She is also the past chairperson, Rssdi Kerala chapter, and has been elected as a governing body member of National API and vice chairperson API Kerala chapter. And she has won many honors, including the Best Doctor Award Modern Medicine 2018 from Government of Kerala, Best Teacher Award in 2019 from the Kerala University of Health Sciences. Over to Dr. Pramod VK from Kannur and Dr. Srinath Bhatt from Kanjangad to chair the session.
Good morning, audience. In fact, I'm the greeting from Bangalore. In fact, I'm attending one of the conferences here. But then this has definitely attracted my focus since the beginning I'm here. We have covered so much, and especially thanks to Dr. Vimal for a wonderful talk. Today, we have Dr. Professor Chandni Madam with us. In fact, she's been already introduced by the organizers. She'll be talking about the management of inpatient hyperglycemia, how to treat and how much to treat. And this diabetes is being such a prevalent metabolic disorder. So much is a problem we are facing in India. In fact, there is a threefold higher chance of hospitalization for all the diabetics. The hyperglycemia, when we say it is almost more than 140 milligrams, and the critically ill patients, there is an incidence of almost 22 to 46% of hyperglycemia. In fact, the increased risk of mortality and complications have this is going to be definitely highlighted by our speaker today. And all of us know that the ideal target will be around 140 to 180 milligrams during the hospital stay. Obviously, insulin is the best option in critically ill patients. And obviously, IV insulin comes in the forefront. OAD is not preferred because of the efficacy and safety studies which are lacking. And of course, DPP-4 inhibitors, with or without basal insulin, we have now evidences. I'm very sure that Chandni Madam will do justice to the topic. I hand over the stage to Dr. Chandni. Thank you very much.
Thank you, Srinath, for the kind introduction of the topic. And very thankful to Dr. Vijay sir, Dr. Sweet, Dr. Balakrishnan, Dr. Arjun, Dr. Joe, and everyone here. And in fact, we were all expecting to be there in Kannur for this meeting, but unfortunately, we are on Zoom platform, but there is a very good attendance for this meeting. That is really wonderful. And sorry, I'll be taking you through the in-hospital hyperglycemia management in diabetes. In fact, I was also been with COVID, Nipah these days, so it was a very tough time, but I'll try to do justice to the topic in my presentation. So, and as Srinath rightly pointed out, it's a very big problem and a very less attended problem as well. Management of inpatient hyperglycemia, how to treat and how much to treat. We are running short of time, so I'll be rushing through some of the topics, but I know everyone has got our own lines of managing patients with hyperglycemia in the hospital, and we fine tune it with the system where we are practicing. So when I was in the morning only, I was just trying through the slides, how to prepare. Incidentally, this slide came to me, so I thought I'll start with this because for us, it's Nipah, and all of us are really struggling. And I dedicate this forward so that we will be more motivated to practice. What we usually do, hyperglycemia in the hospital setting, often overlooked. Admission for stroke, acute MI, but we will be very keen to manage these issues. And when a patient being referred to a center, routinely we discontinue all drugs patients on, and sometimes with high sugar, somebody will be giving some insulin or initiate sliding scale of insulin. And we should be more concerned about precipitating hypo. So, and more people will be involved in a hospital where the patient is critically ill. So they may come with medical history of diabetes, or unrecognized diabetes, stress hyperglycemia, iatrogenic due to various drugs and other things that we use, including the high dose of steroids that we have been using during COVID. So it could be treatment of patients with diabetes who are admitted to the general Medicare wards of the hospital for a procedure or an intercurrent illness. It could be new onset diabetes. And we all seen that the outbreaks like COVID, how difficult it was to manage diabetes in the patient where the patients are in isolation, the treatment of hyperglycemia and critically ill, the perioperative management, the treatment of complications of diabetes, such as diabetic ketoacidosis, diabetes in pregnancy when patient is hospitalized. So these are various situations where we have to manage these patients when admitted to the hospital. And there are evidences, but may not be that robust in all the situations, that management of hyperglycemia in the hospital is associated with increased morbidity and mortality. And if we really understand and we take care of the hyperglycemia, the outcome is better. So there are many studies, but I'm not actually going into that part. So when there are many benefits or risks of loose or tight glycemic management in hospitalized patients, as we have already seen, there is paucity of control trials. What should be the optimum blood glucose level? But we know that very high sugars and very low sugars are not warranted. And stress of the acute illness tends to raise blood glucose concentration, but patient will be with anorexia and other anxiety, delay in getting meals. So there are a lot of issues with regard to the risk of hypoglycemia as well. And the target blood glucose concentration will be different in different setting, and it will be different from outpatient setting as well. And we should have a reliable, frequent monitoring method in the hospital. So we always discuss it as patients in a hospital, non-critically ill or critically ill. And most of the time, diabetes is not the reason for admission and not addressed until after the presenting Medicare problems have been treated. So as clinicians, particularly interested in managing diabetes, I think we could make a bigger change in this scenario. And as Dr. Srinath has highlighted promptly, most of the situations we see patients 15 to 30% having diabetes as the comorbidity wherever we practice in Kerala, in the hospital. So the goals are avoid hypoglycemia, avoid severe hyperglycemia, volume depletion, and electrolyte losses, ensure adequate nutrition, assess patient education needs, and address informational deficiencies. Patient may be having diabetes for a longer time, but patient may be actually not knowing
how to manage the disease, and we have to ensure that the patient goes with adequate education for appropriate management once the patient is discharged from the clinical setting. And our major concern is always avoidance of hypoglycemia, and we do not encourage sliding scale of insulin anymore. So the targets is 140 to 180 milligram per deciliter in critically ill, and in non-critically ill, obviously less than 140 pre-meal and less than 180 post-meal. And we would like to come to as normal as possible, avoiding hypoglycemia. And stringent goals are not really used in the situation of hospitals, except in very limited indications. So the management of hypoglycemia in hospitalized patients always depends upon the type of diabetes, the patient's current blood glucose concentration, and the severity of illness, the comorbidities, the complications, and the expected caloric intake during the acute episodes. We know that some of the patients, they won't be eating anything. So we need to take care of that aspect as well in advising the bolus insulin. And more than that, there should be regular way of blood glucose monitoring, frequency, mode, and we should understand what should be the most appropriate insulin delivery for that particular patient in the hospital. It could be base bolus insulin regimens and never sliding scale. So this is the roller coaster effect of insulin sliding scale, and it has been used when we have been actually monitoring patients with urine sugars, and it is no longer used in the hospital management when the patient is admitted. So what can we do for our patients admitted to the hospital? Document diagnosis in the chart. Hyperglycemia is diabetes until proven, and bring to all clinicians' attention. So everyone should know that this patient is having diabetes mellitus, and note on the problem list phase sheet so that it is never forgotten on the evolution of the disease during the hospital stay. Check hemoglobin A1C. It is a good way of understanding how long the patient is having hyperglycemic. Is it a stress hyperglycemia alone, or the patient is having elevated blood sugars for quite some time? And we need to have a look at the OHS that the patient is having. And if the patient has got hemodynamic instability, hypovolemia, it's better to hold metformin, thiazolidine diones in situations of congestive heart failure, liver dysfunction, and OHS. If the patient is very stable, given for some of the smaller procedures or admissions, we may continue the stable dose as the patient is on. Otherwise, it is also without. And start insulin in patients requiring hospitalization, requiring better control of blood glucose, where we don't know what the patient will be taking, how the patient will be going, whether the patient will be put on in nil orally, but it has to be individualized. And we have many targets, and it has made it is easier for us to titrate and manage our patients. But when we administer insulin in hospital, it is just that what we are trying to mimic the physiological insulin secretion with the breakfast, lunch, and dinner bolus and the basal dose. And the insulin is currently available, any of them, depending upon the situation where we are practicing, we can use. We have a bolus insulin. It comes into the regular or in the ultra fast insulin or faster acting insulins, and the NPH or other bolus insulin as well. And we have the recent faster insulin aspart that is helpful in deciding how much our patient takes, and we can give the dose of insulin before meal or immediately after the meal so that the patient will not go for the hypoglycemia, and we can give as required as per the meal related insulin that for that particular patient. So the prescription of insulin will be basal insulin, bolus insulin, as well as the correction insulin. So we will just calculate, because I think I will have only 20 minutes, so I will not be able to go in depth. And Srinar, please tell me when I have to stop, at least 5 minutes before, so that I can complete it as well, because we are running late and we didn't have a lunch break, tea break as well. So that is basal bolus insulin calculation for a patient weighing 80 kg with a BMI of 28 kilogram per meter square and normal renal function. So we have to decide how to start the insulin in these patients. So we have to calculate the total daily dose. We have to calculate the basal, bolus, as well as the correctional dose. So we have the patient at 80 kg. It's now slightly obese, and this patient is coming to us with some of the problems, and we are admitting this patient with a normal renal function. So we can see that what is the requirement of insulin in a patient If the patient has got a pre-existing insulin requirement or pre-existing dose with us, we can decide on the dose for hospital admission according to the previous dose. May need slightly higher or slightly lower depending upon the situation of the hospitalization. So in a patient he is overweight, we may go for a dose of about 0.45 units per kilogram per body weight. So in that case, in this patient with 80 kg, the total dose will be around 40 units, and 50% of the total dose we will give as basal, and the other 50% we will have bolus. So our basal dose will be 20 units for this patient. Our bolus dose will be 20 units. And basal, we can use degludec, glargine, or NPH, but in hospitalized patient, NPH is a 12-hourly insulin, and if we have very flexible or high fluctuating blood glucose value, a longer acting basal, we have to be very careful, but it may be helpful in some of the situations where the patient is not very unstable. There, the patient will be having a better glycemic control as well. The bolus insulin dose calculation, I have already told for this patient, it will be 20 units, and we can split up into 3. This 3 doses will be like 6, 6, 6, but depending upon the meal, which time the patient is taking the meal, and we can skip the insulin related to the meal when the patient is actually not taking or the patient is going into nil orally. And we have to have a correctional scale estimation. There are tabular columns available to decide on the correctional doses, but what we usually do in clinical practice, if the patient has got a difference of 50 milligram, we add 1 unit. Suppose the patient has got a like the patient is having 350, we wanted a blood glucose of 200 at that time, so we will be adding 1 unit for each 50 milligram, that is from 200 to 350. We can decide as we will be adding 3 units as the supplement insulin along with the meal related insulin that we are giving for that particular patient. So this is how we can decide if we don't have any pre-existing values, but definitely we have a pre-existing dose of insulin on, we can modify it accordingly. And there are situations where we will be administering or we'll be advising on IV insulin infusion. There are many indications, especially when the patient is nil per orally or patient on cardiogenic shock, myocardial infarction, critical care illness, or patient is not very stable, we will be moving on to IV insulin infusion. So when we are going on insulin infusion, what we have to decide is stop all previous insulin orders. Maintenance IV fluid has to be started on dextrose. And when the patient is not on any feeds or not on any riles tube, we have to be very careful about the nutrition part of the patient as well. And it's prepared as 1 unit per 1 ml. So this is how we prepare the insulin unit as 1 unit per 1 hour. And we can start at a lower dose if you don't have any idea about what is the dose requiring for these patients. But usually 2 to 3 units per hour will be starting depending upon the blood glucose level and patient obesity and other risk factors, risk of insulin resistance because of the infection. We can decide what dose the patient will be on. So this is how usually the textbooks say 50 units in 50 ml normal saline, but this is how our sisters do. They take 1 ml, that is 40 units of insulin, regular insulin, and 1 ml they will add to 39 ml of normal saline. So 1 ml insulin they will take, and they will take 39 ml of saline. And this will be 1 ml will be added. So 1 ml, 40 units in 40 ml. That will be the level of insulin in the infusion set. And it is given regular insulin that we usually give 40 units, 40 ml. So we can decide how much we have to give, and we can titrate depending upon the insulin dose of the patient, and adjusting the dose we can do it. But this sort of infusion, insulin infusion pumps has actually helped us in giving the insulin in a very controlled way, and we can monitor very regularly. So this is what we do, but most of the textbooks say 50 ml in 50 units in 50 ml, but for 1 ml is in 39 ml will be 1 ml in 1 unit in 1 ml if we take 40 ml. Okay. So this is how, and the target I have already told 100 to 180 milligram per deciliter, and we can titrate depending upon the dose that we have decided. When we have to modify frequently, and we can adjust the dose depending upon the level of blood glucose that we would like to have, and usually we keep at 140 to 180 milligram per deciliter. We can up titrate, down titrate Or if there is hypoglycemia, we can even stop and train the staff very clearly about managing recognition and management of hypoglycemia. That is also very, very important. And if we have a very good nursing team, it is very easy to manage patient with uncontrolled blood glucose in the hospital. And once a patient in IV dose, we have to know how to we convert from IV to basal bolus regime. Here also it is almost the same. We know how much the patient is taking as insulin infusion. Suppose the patient on 2 units per hour and patient is nil per orally, this 2 units per hour is actually his basal insulin requirement. So that means his total basal insulin that we are giving to this patient is about 48 units. And correcting the stress-related increase of the dose that this patient required, we can reduce to 2/3 of the total 48, and maybe 32 units will be the basal requirement for this patient. How is it calculated? It is calculated on the insulin infusion dose that the patient is receiving. We can take for 4 to 6 hours prior to it. And we can, based on that, we can have a calculation, but we will always decrease the dose because there is always a stress-related increase in dose during hospitalization. And as the patient improves, we can reduce the dose. So this is the total daily dose, means that is the basal requirement because the patient is on nil orally. So total dose will be basal plus bolus. So 50% is basal, means we will have to the other 50% will be the bolus. The total dose in this patient will be about 64 units. And in this 32, we will be giving as basal. We can give NPH, Glargine or Degludec as you prefer. And in our institutions, we usually go with NPH itself and regular insulin for the meal-related insulin. And we can split into 3 doses for the meal-related bolus. But always dose of meal-related bolus has to be adjusted depending upon the patient feed. If the patient is not feeding properly, we can reduce the dose. If the patient is taking normal feeds, we can put it like that. So this is how we adjust the bolus insulin dose. And as we have already told, if there is a pre-meal insulin, we want the pre-meal dose as insulin blood glucose as 150 and the patient is having 300, we can have a correctional dose and roughly we can give 1 unit per 50 milligrams so that if the patient is taking 8 units and the correctional dose 3 units, we can include in this patient.
Dr. Chandini, just I was asked by the organizing people just to remind you.
Okay. How much time?
Maybe another 5 minutes.
Okay.
Fine.
Okay. So,
Thank you.
so this is how we do. So we will be having patients either with IV to oral, oral to IV, and then basal bolus, all these situations, and we have to know how to modify the dose. And converting to subcutaneous insulin, we always start basal slightly earlier, at least 2 hours before, so that it will be easily transition will be easy and the blood glucose control will be easy. And always ensure that patient is eating regular meals. Avoid hypoglycemia and check the glucometer. Glucometers, the current glucometers usually gives very good correct values, but if you have any doubt, correct with the normal blood glucose. So I'll just complete with these 2 charts. Hyperglycemia treatment for hospitalized patient, eating a normal diet. This is what Dr. Srinath was saying in the beginning. Hospitalized patient with diabetes or new hyperglycemia on a general medical ward who is expected to eat a normal diet. So a person coming to the hospital, eating normal diet. If it is type 1 diabetes, insulin-treated type 2 diabetes or significant and sustained new hyperglycemia, we have to start the patient on insulin regime. And if glucose is well controlled, we can continue with the same dose. If you can do either modest reduction or increase in the dose, depending upon the patient meals and patient condition. And in type 2 diabetes not treated with insulin and oral drugs, we can continue outpatient regimen if glucose well controlled and no contraindication are present. But always be careful when we give sulfonylureas. Metformin we usually stop. Pioglitazone also stop when there is a risk of volume retention or edema. And poorly controlled, we will move on to this insulin regime as basal, bolus, and correction insulin that I have already discussed. And when we reverse it, we can actually move on to the reduction of the dose and later maybe patient move to the original dose as the patient is well stabilized and discharged. And in hyperglycemia hospitalized where patient is receiving nothing by mouth, type 1 diabetes, as I have already discussed, and insulin-treated type 2 diabetes or new onset hyperglycemia, we have to go with basal insulin, correction insulin, as the patient starts eating, start giving bolus insulin related to the amount of food that the patient taking. So this is how we manage, and this is actually done by a good team work with you. If you have a good nursing team, it is always very easy and always very challenging when our team is not adequately strengthened up. And really, if we manage diabetes, it gives us a very good outcome, and that is how we are supposed to do. And I'm sure all the clinicians here really will be looking of blood glucose in a hospitalized patient, and will be giving the optimum blood glucose management for them. Thank you.
Excellent, Dr. Chandini. You have done justice to the topic. I'm very sure that our audience have got the benefit out of it. I request now Dr. Pramod, who is my co-chair, to give his concluding remarks. For the paucity of time, I don't think we'll be in a position to entertain any questions.
Thank you, sir. Thank you, Chandini madam. So it was a very informative talk in a very short. Having an important or very in hospital hyperglycemia. As madam is rightly mentioned, patient with the diabetic
I'm not sure. My problem or your voice is breaking.
Your voice is breaking, sir.
Okay. Thank you.
Okay. Is it clear now? Is it clear now?
I think you can speak closer to your instrument, whatever, whether it is mobile or laptop, I think.
You can also try shutting off the video.
Okay, I think it's more clear now. Net problem. Okay, anyway, I think Dr. Srinath can conclude if it's not.
Now you are clear. Yeah, carry
You
on.
can speak, if you kindly speak, Dr. Pramod, if you want to. Otherwise, I think we'll hand over the platform to the organizers.
Yeah, thank you, Pramod. Thank you, Srinath, and thank you, Suresh, Vijaykumar sir, and everyone for the opportunity.
Thank you, madam.
Team, organizing team.
Thank you, Chandni ma'am, for sharing your vast experience with us and enlightening us on the topic. And special thanks to you for being with us in spite of being extremely busy with your strategies on tackling the ongoing Nipah virus scare. Thank you, Pramod sir and Srinath sir, for chairing the session. So participants, please switch on your video for the mandatory photo, which is to be taken for the credit purposes. I request everyone to be patient and switch on their video for 2 minutes.
Okay.
Arjun, I think it's done. Suresh sir, is the photo over?
Yeah, it is over. Rishma, it is over now?
Please unmute.
Yeah, not done, not done. Please switch on your videos.
Is it not yet over?
Not done. Please switch on your videos. Please leave your video on. Okay, it's done. Thank you. Thank you everyone for being patient. So we move on to the next section. Mobile applications for improving diabetes care. And to speak on the topic. Participants, please unmute yourself. Okay, sorry. So we move on to the next section, mobile applications for improving diabetes patient care. And to speak on the topic, we have an expert in the field of technology in diabetes care, Dr. Arun Shankar. He's a medical director and senior consultant of diabetologist at Jyoti Dev's Diabetes Research Center at Trivandrum. Sir is also the chief coordinator for diabetes telemanagement system at the institute. He is also an investigator for various clinical trials with all innovator molecules. Sir is a regular speaker at various national and as well as local Rssdi Diabetes India federations, and he's also the joint secretary of IMA Nemam branch and also a GC member at Rssdi chapter. Okay. So the chairpersons for the session are Dr. Radhakrishnan AP from Palakkad and Dr. PP Vasudevan from Talsheri. Over to you, Dr. Radhakrishnan, sir.
Good afternoon, everyone. And I would like to thank the office bearers of Kerala Chapter Rssdi and Team Kannur for giving me this opportunity to chair this excellent talk by Dr. Arun Shankar. In fact, in short, we have in treating diabetes, we have come a long way from the days where we used to use urine sugar as the monitoring method to adjust your insulin or sugar dosage, sugar medicines. And from next to the glucometer and HMBG, and now we have a CGMS, which we use to look at the glycemic variability. And from days we used insulin syringe, now we have, like Vimal mentioned, the insulin pump with the AI facilities. And also the new apps, which can see the variability of the glucose, both by the patient as well as the doctor. So to talk on this and give it to enlighten us, we have a Dr. Arun Shankar, eminent speaker who have immense experience on this field. Over to you, Dr. Arun Shankar.
Good afternoon. Am I audible?
Yes.
Thank you, Radhakrishnan sir. I'm not able to share my slides. Dr. Arjun, can you help? Really sorry for the...
1 second, sir. 1 second.
Yeah.
Okay, sir, now? Yes, sir.
Yeah. So the slides are visible, right? Thank you. So at the outset, let me congratulate the entire team of Kannur, Rssdi, IMA, and Physicians Club, and particularly Dr. Balakrishnan sir, Prashant sir, Joe sir, and dear Dr. Arjun. And I would like to congratulate them for coordinating this quarterly meeting excellently. And like what Dr. Radhakrishnan sir was mentioning about the topic, this is totally different from the discussions which we had in the early morning. We were listening more about newer molecules, inpatient management from Chandni ma'am. But what I'm going to discuss is totally different. So these are the challenges we are facing while managing our diabetes patients. Let it be to deal with glucose control, blood pressure control, and the newer area of focus which Rssdi is also getting into with more actions task force involved in weight management. So here we are focusing to detect and prevent complications as well, including the patient influenced by different factors, including behavior, and these all should be dealt with into a 24/7 care being given to the patients, which is the area like mobile application will be helping your subjects and your team as well to deal these things. So the importance of connected devices, these are the physical objects that connect with each other and other systems with the help of internet. So while discussing mobile applications, there is the importance of these things being connected together to have a better outcome as well. These devices are embedded with technology like processing chips, software, sensors, and thereby the data being collected and shared with the other devices and systems to have a proper decision making while managing blood sugar, blood pressure, or any other factors which I have discussed earlier. So these connected devices usually utilizes various wired and wireless networks, including Wi-Fi, NFC, Bluetooth. So these things being highlighted here, let it be the flash glucose monitoring, the smart blood pressure monitoring, smart watch with which will be helping even to get ECG, then the artificial pancreas, which Dr. Vimal was explaining in detail. So these all need the help of a mobile application where you get the data being collected and stored, and that can be assessed in a proper way to have a better clinical outcome. So the most popular application which the patients are using by themselves comes so many applications are available, but the most popular being the MySugar app, where you can see the entire aspects of diabetes management being highlighted in this particular slide. So any diabetes patient can use this. Pardon? Any subject with diabetes above the age of 16 years who can actively involve in diabetes self-care, who are physically and mentally able to independently manage their diabetes in a proper way, can use this app efficiently with the help of the smartphone, which every people are having nowadays. So this MySugar app can be used on any iOS or most Android smartphones. In this particular app, there is a diabetes monster, which is very interactive one, which gives quirky sounds that helps you identify the variations in your blood sugar patterns. And taking definite actions for caring your diabetes gives you points. Thereby, you can have a proper motivation among your patients to have a better glycemic control. So you can earn recognition in the form of points for each action taken to care for yourself and your diabetes. If you hit 50 points in a day, you have tamed your diabetes monster. And remember, the more you log into this app, the more you know and the easier it gets to tame the diabetes monster. This will help to have a proper idea of your patient's blood sugar pattern so as to have a proper decision in treatment modification, let it be to do with lifestyle or the medication part. This app can help any of your diabetes patients, including type 1, type 2, or gestational diabetes, because there is something to deal with carb counting, glucose tracking, bolus dose calculation, whereby the patient can titrate the insulin dosage easily, ending up with hypoglycemia or addressing the hyperglycemia as well. It can give a detailed report of blood glucose levels over weeks, months, and years. And to know in detail, you can have a HbA1c level based on this tracking. But for estimating HbA1c, the app requires 21 days of SMBG data. And that too, it need to have 3 data each day. So the patient has to enter the or monitor the blood sugar as per this requirement. Should not have a gap of more than 2 days from previous entry, and 3 days of consecutive login is also mandatory. So here you can have an HbA1c level assessment with tracking, proper tracking with the usage of this app. MySugar also features that can help you make the maximum out of this app, such as reminders that ping your subject to have idea of more about your blood sugar trends after like exercise or a particular diet. All these data can be easily shared with the doctor's office or the team involved in diabetes care so as to have a proper decision making as and when required to control patient's blood sugar pattern. The app can be connected with Apple Health, Google Fit, and it is available on Play Store and Apple Store as well. So the real world evidence, you can see very clearly that over 2,000 highly engaged users of this particular app using was shown that to have a better glycemic control. Let it be with the mean blood glucose level or the glycemic variability, which we focus nowadays. You can see after a period of 6 months how efficiently this app has helped the patients to have a better glycemic control as well. The next one which I'm going to discuss is about Diabetes M, which is a digital diabetes logbook app that records how much insulin, when, where it has been taken, your subject's blood glucose level, and what have eaten. Users can also log exercise, medication, and other metrics, including blood pressure, pulse, cholesterol. Everything can be entered. So Diabetes M also has a built-in bolus advisor, where the multiple daily injection taking patients or the insulin pump patient can calculate the bolus insulin dosage and modify the dosage according to the blood sugar trend being observed with the help of these applications available. Here it is also available in iOS and Android platform. The app has been optimized for phones, tablets, Android, Apple smartwatches, and other features include where you have the entire list of common foods which the patients are using, and the graphs, analytical charts, and the reminders are also available in the Diabetes M app. The other most popular one application is the One Touch Reveal app. Here you can clearly have the glance of the patient's glycemic trend, where the percentage of time in range in being maintained by the subject can be known with the help of this particular app. And this very well works with the glucometers, which we can use among the patients. And clearly it has shown that the lifestyle changes what the patients have doing, let it be with the exercise part or the diet part, that can be entered in this application, and the glycemic trend can be observed. When and where it is required, you can act accordingly. Using the blood glucose readings, the app automatically search for the high and low trends. And also this app helps spot glycemic trends and push notifications where the patients will be getting alerts as and when action should be done after seeing the blood sugar trends. The app plots important trends, events in a timeline, to helping the user to spot patterns. Here again, the physician can log in to review patient history and adjust their care plan according to the blood sugar trend which has been observed from the app, and the diet change or the medication change can be decided accordingly. And of course, the evidence what we have seen with the usage of these particular apps, in this particular study, then type 1 diabetes, it has been shown that HbA1c levels improved with those subjects who were using the Bluetooth connected blood glucose meter when compared with the help of an app, when compared with those patients who were just using the blood glucose meter alone. And from our center itself, we have published the data from this study that this was done to assess the changes in glycemic control and overall experience of patients using the application in conjunction with Bluetooth enabled One Touch Video Flex blood glucose meter. The subjects were more than 18 years of age, diagnosed with type 1, that is total of 13, and type 2, total of 47, with an HbA1c less than 11%. The glucose readings were instantly captured in the smartphone and web applications for the patient and physicians, thereby reducing the time frame required for a clinical decision making. But with the usage of this application, the motivated patients or the patients who were comfortable with using this application were having a better glycemic control, and the data was published in the DTT 2020. And the next one is Glucose Buddy. Here again, you can have it from Play Store and App Store that provide proper tracking of blood glucose, HbA1c, meals, carbohydrates, medication, physical activity, the medication timing, glucose measurement reminders, and also to assess HbA1c calculation. They have both paid and free versions as well. Here again, patients have to enter the data. The Glucose Buddy app can integrate again with the Dexcom CGM sensors, that the most perfect continuous glucose monitoring system available, and the Apple Health apps allowing you to more easily track steps, exercise, and meals. You can also enter your information manually. The app offers a 12-week diabetes education plan to access easy-to-read tips with some lessons, 5 minutes and under. Users can chat with the diabetes educator within this app. So the other most commonly used app include the BESI T2D, an online community app to discuss anything and everything related to diabetes. It is free to use and it can connect with others having diabetes, where you can have discussion regarding diabetes, not only diabetes, and the entire aspects of diabetes can be discussed in this particular app. This is the particular app that is the BESI T2D. And you have so many food-related applications available where the patients or the team themselves can calculate regarding the carb and the diet management according to the treatment protocol which you are advising for your particular patient. So all those food-related apps will definitely help the patients who are motivated to use for their better glycemic control to be achieved with these applications. So we are more focusing on patients' glycemic variability nowadays, which was clearly discussed in the previous discussions as well. So the flash glucose monitoring, among the flash glucose monitoring, we are waiting for the newer Freestyle Libre 3 as well, the real-time continuous glucose monitoring. Here, there is no need to scan the sensor every 8 hours, and it is 70% smaller than previous models which we are using right now, making it the smallest and the thinnest continuous glucose monitoring sensor, where the patients are more comfortable, because nowadays we are more into user-friendly approach to have a better usage or compliance from the patient's part as well. And it is cleared as an integrated continuous glucose monitoring. So here you have the Libre link up, the Freestyle Libre having an app which allows you to monitor patients' glycemic variability or the blood sugar trend, and you can share patients can share your glucose readings with the team involved in diabetes care. Not only that, the patient can share this data with their dear ones as well. The share is up to 20 people. So the glycemic trend being observed with the help of this new sensor can be shared with the treatment in a team involved and the caregiver as well, so as to avoid the huge glycemic variability, that is the hypos, which we are very careful when we are dealing with type 1 diabetes as well. So another one is the CareLink Connect developed by Medtronic, which is available in Google Play Store and Google App Store as well. The application currently supports the Minimet 770G system and the Minimet 780G, which was clearly mentioned by the previous speaker, Vimal sir. The application allows the healthcare provider or the care partner to monitor patient diabetes information in their CareLink account being provided for that particular patient. Here again, you have the advantage of having known the data of the patients to avoid the so-called blood sugar variability and to prevent hypoglycemia for particularly those brittle diabetes patients, including type 1 and other brittle type 2 diabetes patients as well. And the standalone device, that is the Guardian 4 Smart CGM. Here you have the sensor, the 7-day wear sensor, and the transmitter, Guardian transmitter, and the CareLink personal software, also with the help of Guardian app. Again, you can share the data and have a clear idea of the glycemic variability in not only those patients who are using insulin pump, multiple daily injection treatment continuing patients as well get the benefits of these CGM and the apps to have a better idea of glycemic pattern and to modify the lifestyle and treatment. So definitely the connected devices make a difference in diabetes management. It makes life easier, flexible, reduces the cost, and of course, reduces the complications for your diabetes patients in future as well. So you have so many connected devices in diabetes management, starting with smart weighing scale, blood glucose meters, which I have discussed earlier itself, continuous glucose monitoring, insulin pumps, that the sensor augmented insulin pumps available, the connected pens, smart wearable ECG monitors, smart socks, so many things which are connected along with the help of these applications will have an impact on better glycemic control. So the smart weighing scale, where the one is being connected with the help of Bluetooth or Wi-Fi, the body scale can be connected to a smartphone or a tablet to have a better idea of the trends, insights, and the body mass index calculation, body fat level, visceral fat, all these things can be recorded and tracked with the help of applications, mobile applications along with this available. And the connected BP apparatus. Here again, the Wi-Fi enabled BP monitors provide the heart rate measurements with immediate feedback on the device and full history in the application. You can track and record the data over time, share with the healthcare provider or the team involved in management so as to act immediately. Certain BP monitors include a digital stethoscope and ECG as well. Then you have the smart thermometer for insulin and medications. So this one helped your patients to have an idea of the storage of the temperature storage of particular drug, including insulins or other oral agents. And the connected glucose meters, here again, it was described along with my sugar applications, which in the initial part itself. And you have the connected pens, the reusable injector pen with an intuitive smartphone app that can help people with diabetes better manage insulin delivery, where the calculation and the tracking of doses, and it has the details of the where the patients can avoid the extra dosage being administered, including the elderly subjects. So the connected pens will help in this area. These are the connected pens, the tracking insulin pens, smart insulin caps, the schematic representation of the connected insulin pens and the connected insulin caps available. And definitely the studies have shown that the usage of connected pens have helped in better glycemic control, to have a better time in range among those patients who are using it regularly. So these are the other connected pens available. And wearable ECG monitors will enable continuous monitoring of ECG as well, and early detection of abnormal cardiac rhythms or other cardiovascular issues with the help of ECG on Apple Watch, the Apple Watch Series 4, Series 5, 6, 7, Series 8 and Ultra. There you can have the assessment of any changes in cardiac rhythm or the cardiovascular risk involved in your patients, to have immediate action wherever it is needed. And smart socks available. The startup developing washable smart socks for people with diabetes. Continuous monitoring of food temperature at 6 key points to detect signs of inflammation is possible. And wearers and the doctors receive notification via an app and the text messages when inflammation is detected. And you can see that the different points being highlighted here, those patients who are at risk of having this foot ulcers or developing of foot ulcers in future can have an advantage of using these properly, so as to avoid complications while we see in managing type 2 diabetes. So definitely with the usage of the connected devices, including the mobile applications, definitely you can have a better glycemic control among your patients, where at the one end you have the patients with diabetes using the modern gadgets or the tools available with them, who are motivated enough to use it properly as advised. Because if it is not being used in a proper way, the result will be not that favorable. And the data being collected with the help of these apps can be transferred to the team involved in diabetes care, as well as the caretaker who can help the patient in somehow. So that the team involved in diabetes care will have a proper feedback to the data being observed from the patient's file or the applications, to modify the treatment in a way so as to improve the quality of life, and as well as to have a better glycemic control to prevent the so-called micro or macrovascular complications which we see among our patients in future. So to conclude, the newer technology day by day is going to improve your patient outcome if these connected devices, including the all mentioned devices, will be in a proper usage with the help of mobile applications, will help your patients to have a better glycemic control and to improve quality of life. Thank you.
Thank you, Dr. Arun, for the excellent talk. Dr. Arjun, is it Dr. Vasudevan is on the line, or should I conclude?
Vasudevan sir, are you there, sir?
Hello.
Yes, sir, you're audible.
I'm audible.
Yes, sir.
Yeah. Thank you, Dr. Shankar. You have opened a Pandora box of information that through digital more than facilities available at your fingertips. And thank you so much that you made the whole thing in a nutshell and presented it. There are a lot of questions coming up in the chat box. Because the meeting is cruising in a very smooth manner, though late. So I think we can't entertain so many questions. Somebody is asking about the smart socks. You know? Can you enlighten on it, Arun? Am I audible?
Yes, sir. Yes.
Hello? Yeah. Okay. I should thank the organizers for making this wonderful meeting proceeding along so well, and I should thank the speaker Arun Shankar for enlightening us so well. But what is required is measures to educate the patients as well as the doctor community and the healthcare community to make these things available and amenable to the larger patient community. Thank you, Arun Shankar, for an excellent talk, which we all have enjoyed. Thank you so much.
Thank you, Arun sir, for explaining these apps to us, and thank you, Radhakrishnan sir and Vasudevan sir, for chairing the session.
Wow.
Thank you.
We move on to the next session. A very important topic in clinical practice, because a very wrong diagnosis in a young onset diabetes patient can actually do more harm than benefit to the patient. And to speak on the topic, diabetes in young, diagnostic possibilities and treatment challenges, we have an expert in the field, Dr. Sunil Prashobh sir, who is a professor of medicine at Government Medical College, Kollam. Sir has done his MBBS and MD from Government Medical College, Trivandrum, and his postgraduate diploma in diabetology from Annamalai University and Johns Hopkins University. He is a regularly invited speaker for various conferences and has publications in national and international journals. I hand over to the chairpersons, Dr. Jayalakshmi R. Kurup from Kochi and Dr. Janathan Naik from Kasaragod.
Thank you, Dr. Arjun. Am I audible?
Yes, ma'am, you're audible, ma'am.
Okay, thank you, Dr. Arjun. At the outset, I would like to thank Dr. Vijay Kumaran sir, Dr. Balakrishna Valliyod sir, and the entire team of Rssdi organizing committee and team Kannur for giving me this opportunity to be a part of this meet. I'm Dr. Jayalakshmi R. Kurup from Cochin, chairing this session along with Dr. Janardhan Naik sir from Kasaragod. The prevalence of diabetes in children and adolescents is increasing worldwide with profound implication in the long-term health of an individual. Although type 1 diabetes is more in children and adolescents, the incidence of type 2 disease in youth and is also on the rise. Overweight and obese children and adolescents are presenting with type 2 diabetes associated with insulin resistance. So diagnosing, treating, and managing the diabetes in young people could be a real challenging task. To elaborate on the topic of diabetes in young, diagnostic possibilities and treatment challenges, I would like to invite Dr. Sunil Prashobh P., Professor of Medicine, Government Medical College, Kollam. Over to you, Dr. Sunil.
Shall I share the screen, Arjun?
Are you able to, sir? I'll just...
No.
You're not.
Disabled.
Yes, one second. Just a second, sir. Yeah, you can try now, sir. Slides are visible, sir.
No, it's visible. I hope I am audible also, Arjun.
Yes, sir. You're audible, sir.
Okay. Thank you, Chairperson, for the kind introduction. Let me at the onset itself thank Rssdi Kerala chapter for this fantastic opportunity. And a special thanks to Balakrishnan Valliyod sir and Arjun again for this opportunity. So my topic is diabetes in young, diagnostic opportunities and treatment challenges. It's a very, very important topic that all of us should know. Now, diabetes is growing in epidemic proportions, we all know. And in the recent past, diabetes in young age group is also growing in epidemic proportions. So let me invite your attention to 4 cases which I saw in the recent past, a couple of weeks back. All of them were young, to the age of 20, 26, 18, and early 30s. So all of them are young onset diabetes, but mind me, all of them are different types of diabetes. Everyone is different. So this is very, very important. Now, that diabetes disease is a continuum. At one end of the spectrum, there is an autoimmune disease, predominant type 1 diabetes, and at the other end of the disease, there is a metabolic dysfunction, predominant type 2 diabetes. And in between, there occurs so many different types like LADA, MODY, early type 2 diabetes. So many varieties of diabetes do occur, and it is not a single disease that we see. But whatever is the subtype of diabetes, the dysfunctional beta cell is the final common denominator in all diabetes, irrespective of the subtype of diabetes. So this is a classification of WHO classification of diabetes, which came in 2019. There are different types, including type 1, type 2. There is a hybrid form of diabetes, like slowly evolving immune-mediated diabetes of adults. There is a ketosis-prone type 2 diabetes. Then there are special types with special mention on the monogenic diabetes. There are unclassified diabetics like the protein deficient diabetes. So when it comes to the type 1 diabetes, all of us know the basic aspects of all these things. Some amount of autoimmunity is there, and many of these patients will be having an associated other autoimmune features. And all of us know that once the disease starts, there is a sudden decline in the beta cell function, and the patient will be bound to insulin lifelong. So these are the features of type 1 diabetes, which all of us know. There will be abrupt onset of symptoms of diabetes, lean patient, no family history, there is ketosis, absolutely absent C-peptide, positive anti-GAD antibody or islet cell antibody, and the patient will be insulin dependent for lifelong. And this is a very, very important thing. We always will have to do this anti-GAD antibody. Anti-GAD antibody has got a very high specificity to the tune of 99% and very high sensitivity. We can also do islet cell antibody. So for defining the type 1 diabetes, the anti-GAD antibodies plays a very, very important role. The other forms of young onset diabetes that we see are the monogenic diabetes, of which maturity onset of diabetes of young adult is a very, very important thing. There is also neonatal diabetes in patients below the age of 6 months. So monogenic diabetes, it is not that we don't see monogenic diabetes. We do see monogenic diabetes in our clinical practice. The diagnostic criteria is age less than 25 years of onset, the autosomal dominant transmission with 3 vertical generation involved. There is absence of ketosis, and many of these patients may be treatable with sulfonylurea, secretagogues. They will respond to sulfonylureas, and genetic analysis is a must to confirm the diagnosis of MODY. So always the pedigree chart, a family charting is very, very important, and you will notice that there is some 2 or 3 vertical generation of young onset of diabetes in all of these patients. So this is a beta cell which shows that the monogenic defect is at different levels. The genetic defect causing beta cell secretory function is at different levels. The most important types of MODY are 2, the hepatocyte nuclear transcription factor mutation, which is occurring at the level of endoplasmic reticulum, and also it can happen at the glucokinase level. So what happens is the glucokinase mutations are relatively benign, onset of the birth, and the complications are rare. But if you look at the transcription factor mutations, they usually occur at around the adolescent age group. They are cause progressive hyperglycemia, and the complications are also frequent. And as such now, around 14 different types of MODY has been found out. So we should always know our clinical practice, how to differentiate MODY versus type 1 and type 2. MODY is always young onset diabetes around the age of early 20s. The patients will be coming non-obese patients. There will be a single gene defect affecting beta cell secretory function. Some amount of C-peptide will be there. Anti-GAD antibody will be negative, and most of these patients will be treatable with sulfonylurea. So this is the most important aspect of MODY. And genetic testing, as I have told, genetic testing is very important to confirm the diagnosis. But of course, from the clinical manifestations, which I have told, we will be able to make a clinical diagnosis, but the genetic confirmation is needed to confirm the diagnosis. The treatment of MODY, I have said, the MODY 1 and 2 is actually treated by sulfonylureas, and the benign-looking MODY 2 usually does not require treatment. And some of the other MODYs, you may have to treat it with insulins. There is a huge data available from the Mohans Institute. They have a big registry of this monogenic diabetes MODY, which is available, and they have got huge data and several publications from South India regarding several MODY patients. And what is being said is that Mohan Institute, they have found out 10 different types of MODY. There is a big data available from CMC Vellore also that our population, there are so many cases of MODY in our population. Another important type of diabetes in children below the age of 6 months, that is neonatal diabetes. It is also a type of monogenic diabetes. And the most important aspect is many of these patients are treated with sulfonylurea. The insulin is actually not needed. They can be treated with sulfonylurea. Another very important type of diabetes that we see in younger age group is the early onset type 2 diabetes. Nowadays, we are seeing patients in early 20s, even in patients with 16, 17, 18 years, patients do come to our clinic with early onset of diabetes. The most important thing is these patients will be having features of insulin resistance. They will be having high body mass index, and their C-peptide can be high on a high range. The anti-GAD antibody will be negative. And these patients, the treatment is OHA, the insulin sensitizers are the treatment of choice. Now, of course, the risk factors for the early onset of type 2 diabetes, all of us know the overweight, unhealthy diet, poor physical activity, the gestational diabetes, and regarding the marker hypothesis, which has been previously told by one of the earlier speakers, was commenting about this marker hypothesis. So another important type of diabetes in young onset worth mentioning is the ketosis-prone type 2 diabetes. Ketosis-prone type 2 diabetes. This was reported mainly from the Saharan Africa, African Americans, and Chinese population. The thing is that in the initial presentation, they will be presenting, most of the patients present in after the age of 30 years. And initially, they will be having an aggressive course, very aggressive course. Many of them may be presenting with ketosis. Autoantibodies will be negative. Insulin in higher doses may be needed in the initial stages. But after some 2 to 3 months, the aggression comes down and they behave as a normal type 2 diabetes. And many of these patients can be managed with type 2 diabetes. So it is said that initially they behave like a type 1 diabetes and then they behave as a type 2 diabetes. And it was first detected in the suburb area, the Brooklyn in New York, and a suburb area called Flatbush, and that is why it is known as Flatbush diabetes. There is a data from CMC Vellore by Nihal Thomas and all. There is a cohort of patients in our population also. Such group of Flatbush diabetes do exist, and you can search the literature. There is a data from Vellore. Another important type of young onset diabetes that we see is LADA, that is latent autoimmune diabetes of young adults. And they are called 1.5 diabetes because they behave both as type 1 diabetes and type 2 diabetes. Why type 1 diabetes is because the anti-GAD antibody will be positive. And why they behave as type 2 diabetes is because in the initial 1 or 2 years, most of these patients will be responding to OHA. That is why they have features of both type 1 and type 2 diabetes. And that is why it is called as 1.5 type of diabetes. Now, the thing is that what makes this LADA patient different is the beta cell failure in this LADA patients is quite faster. In 2 to 3 or 5 years, the beta cell dysfunction happens very quickly and the C-peptide level will come down very quickly. That is why the most important thing, the C-peptide level, initially itself, the C-peptide level will be to the tune of 2 or less than 2, and the C-peptide decrease comes down very quickly. So the most important thing is these patients, the beta cell preservation is the most important aspect of these patients. We should try to give insulin in the early stage itself. Don't use sulfonylurea. We should try to preserve whatever beta cell is there and start insulin at an early age. Now, in our clinical practice, we do see patients of this type in early 30s and early 40s. These LADA patients, we do see so many patients of LADA. And the most important aspect is the tendency to develop ketosis. The tendency to develop ketosis is more in type 1 diabetes than LADA, than type 2 diabetes. So this is one important point. So as I have told, there is a visualization of the overlap. This is a spectrum of disease, and many of the manifestations, there can be overlap, like the immunity, the genetic aspects, the BMI, all these, there is a overlap between these spectrum. Now, another group of patients which are commonly seen in Tamil Nadu, Kerala, is a lean patient. They may be having abdominal pain in the first decade, and in the second decade, they may be having features of malabsorption, steatorrhea, will be having severe diabetes, no ketosis. The most important thing is just an abdominal X-ray, an ultrasound that will clinch the diagnosis. That is a fibrocalcareous pancreatic disease. There will be calculi mainly in the pancreatic duct. So this is a very, very important condition if young age onset diabetes that we do occasionally see in our part of the world. There are so many other causes of secondary type of diabetes, which I am not going in a detailed aspect, but one worth mentioning is the steroid-induced diabetes in young group of population. The steroid-induced can cause insulin resistance, and some of our patients in a very early age, they may come up with diabetes. So this is another important thing. So not only that, in young age population, if we happen to see very big obesity, neurological manifestation, deafness, we should always think in terms of some congenital syndromes or conditions like DIT-MOD, which is nothing but a mitochondrial gene disorder disease. So whenever if you happen to see things like this, always think that it could be some part of a genetic syndrome. Another important type of young onset diabetes, which is not given much importance these days in our guidelines, is a protein deficient diabetes mellitus. It was there. It was reported from northern states like Bihar, Orissa, like Bengal, and all. There are some cases with protein deficient diabetes, but not seen in our part. It is especially seen in rural areas where there is severe malnutrition, and many of these patients will be presenting with very high blood glucose. Onset below the age of 20 years, they will be lean, and insulin will have to be used in those group of patients. This is protein deficient diabetes. So whenever you are approaching a patient of young onset type 2 diabetes, the two important things are clinical indicators and biochemical confirmations. The clinical indicators are the history, the family charting, then the signs of insulin resistance. All of these are very, very important. Along with that, the two important investigations that we should always resort to is the anti-GAD antibody and the amount of C-peptide. C-peptide is an absolutely important investigation in this group of patients because all of us know C-peptide is a co-secretory product of insulin, and it helps us to differentiate between type 1, type 2, and LADA. So this is the fasting serum C-peptide level is a very simple test which helps us to guide in this direction. So whenever you are approaching a differential diagnosis of diabetes in the young, this is the chart. This is a comprehensive chart which is available. Look at the family history, 3 vertical generation of family history. Some amount of C-peptide is there. Patients are non-obese, anti-GAD antibody negative. Always think of MODY. If 3 vertical generations are not there, but just the mother or father is having a diabetes, signs of insulin resistance is there, C-peptide may be on a higher side, think of early onset type 2 diabetes. If the family history is not there, but the C-peptide is completely absent, anti-GAD antibodies are elevated, think of type 1 diabetes. And if no such family history, patient having abdominal pain, steatorrhea, an X-ray showing calculi, that is fibrocalcareous pancreatic disease. Now coming back, the unlocking dilemma, the first slide which I showed 4 young patients. And the diagnosis of the first patient was, he was a 20-year-old male. He came to me with a very high blood sugars to the OP. He was having acetone positivity. And when I checked, the serum C-peptide was below 0.01. And the anti-GAD antibody was very much elevated to the tune of 186. So this is a straightforward case of type 1 diabetes. The second patient is a 26-year-old female. She was non-obese. When I pieced the family, that generation, family history was, young onset family history was there. She was non-obese and her C-peptide was to the tune of 1.8. GAD antibody was negative. She had a mild fasting hyperglycemia. So clinically, I could make out the diagnosis of MODY in this patient. The third patient is an 18-year-old obese patient, Aditya, who came to my OP, and he was having a very high blood sugars. He was having features of insulin resistance like obesity, acanthosis nigricans, fatty liver. All these things were there, and his C-peptide was to the tune of 4.5. So this is a case of early type 2 diabetes. The fourth patient is a 35-year-old patient. who is under my treatment for the past 10 years. Actually, when she presented 10 years back, she was having 34, 35 years of age. Her anti-GAD antibodies were positive. She had some features of insulin resistance. She had C-peptide to the tune of 1.8. So initially, she responded to OHA, but as I could find out that anti-GAD antibody was positive, shifted her to insulin. This was a case of LADA. So the most important thing is why we need to make out all these young diabetes is because of the management. There is a difference in the management. And we all know that type 1 diabetes, LADA, FCPD, all these are managed with insulin. When it comes to MODY, some of the MODY usually responds to sulfonylurea. The neonatal diabetes, of course, sulfonylurea. And the early type 2 diabetes, the insulin sensitives like metformin, weight loss, exercise, all these plays a very, very important role. So just to summarize what I was trying to convey the last 10 to 20 minutes, there is an increased prevalence of young onset diabetes in our society. The most important differential diagnosis we should all know, the most important are type 1 diabetes, MODY, LADA, and early onset type 2 diabetes. And we should know how to differentiate between these 4 types. There is a clear difference in the clinical features. There is a difference in the management. And the most important thing is always make use of the antibody checking, the antibodies and also the fasting C-peptide, which will clinch the diagnosis. And I have clearly told the importance of diagnosing each type of young diabetes because that is going to matter a lot to the young patient. Once again, a real thanks from my bottom of heart to the Research Society for Study of Diabetes in India for this fantastic opportunity. Thank you.
Thank you, sir. Thank you very much for your excellent and very informative talk on diagnostic possibilities and treatment challenges in young diabetics. Young people with diabetes are more prone to develop disease complications, not only because of the long duration of the hyperglycemia that they accumulate, but also due to the inherently aggressive nature of the disease and suboptimal control. Of course, accurate diagnosis and combined with the regular follow-up and maintenance of optimal glycemic and risk factor control by judicious use of the available therapies will ensure that these young people enjoy a long, fruitful, and complication-free life in spite of diabetes. Sir, one of your slides shows that the last patient, fourth patient, he has vitiligo and hypothyroidism. Also, all these are related with the LADA.
Yes, that is what I told, sir.
These LADA,
these patients will have some features of autoimmunity, and anti-GAD was positive, and she had vitiligo. She had hypothyroidism also, Hashimoto's hypothyroidism. So some amount of autoimmunity is there. And when she presented to me, she had some features of insulin resistance also, and her C-peptide was 1.8. That is why I made a diagnosis of LADA in this patient. Vitiligo was initially not present. It developed after 1 or 2 years later.
So the anti-GADA and the C-peptides, all these investigation, at up to what age we have to advise? Is there a cutoff point?
Sir, no, actually what is being said is in young onset, we definitely do this, but the LADA, there is no clear cut. LADA is supposed to be present in the initial 30s. That is what the classical definition, but what is being said is LADA can even be present in 40s and early 50s. And so there is actually no cutoff, but we usually do anti-GAD antibody above the age of 40 years, we don't do usually.
Thank you, sir. Any more questions? I don't see any questions in the chat box. Jayalakshmi madam, do you have any questions?
No, sir. That's all.
If no more questions, let me express my sincere gratitude to Dr. Balashna sir, Dr. Arjun, and Rssdi and Christian Club Kannur. Thank you very much. Thank you, Sunil sir. Thank you.
Thank you, sir. Thanks.
Dear friends, now we'll move to a very interesting debate on the topic of reversal of type 2 diabetes. Now, this is one of the most important contemporary hot topic in medicine, and experts across the globe are divided on the topic. And today we have got two eminent faculties to debate on this interesting topic, none other than Dr. Hanif and Dr. Raju Gopal. And first, we will invite Dr. Hanif for his deliberation on the topic, and let us hear what is their conclusion. And Dr. Hanif has got his MBBS from the Kottayam Medical College, completed his MD Medicine from Chipmar, Pondicherry, and he was awarded the Fellow of Royal College of Physicians in London. And he is an eminent physician practicing in Kannur and very popular, and he is an academician. And his area of interest is in tropical medicine, diabetes, training and education of the postgraduates, and again, other pursuit like long distance cycling and amateur wilderness, and he has got many extracurricular activities. Now, over to you, Dr. Hanif, for your deliberations.
Thank you, sir. Shall I share the screen, sir?
Yes, sir. Oh, wait.
Arjun, can you just disable that?
Yes, sir. Yes, no. Sir, can you try now?
Yeah, I'll just try. Just a moment. Is it visible?
Yes, sir. You can proceed.
Yeah, okay. Very good afternoon. Actually, I'm asked to speak on a subject which is a bit difficult because everybody will think that.
Just 1 minute. Just 1 minute. For this topic session, we have got two eminent chairs. One is Dr. Ajit Kumar Shivashankar from Trivandrum and Dr. Harish. And I think they are ready to join. Please.
Yeah, I am here.
Okay. Yeah. Okay, to the chairperson.
Yeah. Hello, Balashn. Yeah. Good afternoon. Thank you, Dr. Balashn and Dr. Arjun, for giving me this opportunity to chair this important session on remission of type 2 diabetes. So, before starting the topic, as you all know, type 2 diabetes, there is a stage of normal glucose tolerance, stage of pre-diabetes, and clinical diabetes. Remission is possible only during this stage. When you go for complication, you won't be able to have remission. And remission means a return of HbA1c below 6.5 percentage. And for remission possible, we should have many people have tried different methods, and also we have we should have a low calorie diet or a low carbohydrate diet for at least for 3 months in the absence of pharmacotherapy. And there is no keto diet. So as you all know, there's an important study called direct study. Dr. Roy Taylor, yes, study has proved that if we have diabetes less than 2 years, we'll be able to have remission, and up to 5 years. So remission is possible if you have a weight loss around 15%, and which can be maintained. So we should have a 10-year period for a remission to. So we will hear more from Dr. Hanif, his views and his debate on this topic. Thank you.
Thank you very much. Good afternoon, everybody. I think it is we are extending beyond the lunch time, so I do not want to stretch my talk too long. So to be very crisp on the topic that is being given to me to talk on remission of diabetes, and this being a debate, I will actually be debating for remission of diabetes because few of my patients, at least few of my patients, have made remission a reality. Now, before going to the topic per se, I would like to say that I do not have any conflict of interest in this particular presentation. And I would like to begin with the statement that prevention is always better than cure. A few of my previous speakers have elaborately discussed about the therapy that is available, including the most recent advances in the treatment of diabetes. But I would like to concentrate something on prevention, because I don't mean to say that I'll be able to prevent all cases of type 2 diabetes or cure the diabetes, but it is still possible to prevent the progression of few cases in preventing from progression from pre-diabetes to diabetes, as well as prevention of complication, which is also a big burden for the diabetic patients. An outline of my debate will be on what is remission, why remission is important, and how do we achieve remission, and for whom we should be considering or offering the remission. And I would have one concluding slide. Now, if you look at the problem, you can see over the last 50 years, there has been an increase in the number of obesity of patients as well as diabetes. And in the beginning, you would have listened to Vijay Kumar sir mentioning that it would be watching him who has been taking 4,000 calories per day and ending up with diabetes. We do have best practice guidelines available from various corners of the world, but despite the fact that having all these best practice guidelines, we never been able to bring down sugar level to the extent which we call normal normoglycemia, which is not possible. And various studies have shown that such a possibility exists only in 0.25%. Conventionally, type 2 diabetes is often a progressive disease, whether it's muscle function, and mostly it has been regarded as a irreversible disease. But until 2016, there was actually no mention about the entity called remission. Some people put it as a reversal. I do not agree with the reversal because the consensus is only about the remission. Let's see, even today, the remission is not a standard area of practice. I doubt even till yesterday, nobody would have really mentioned how many patients who is approaching the clinician will be given an option of remission. We always tell them about the dietary control, then give them some drugs and ask them to come back and see with blood. Very seldom we offer the possibility of a remission. Now, hereafter, I think we should also be discussing the possibility of remission, all those patients who actually fit with those categories. Now, regarding the remission, the textbook description or the dictionary description of the remission of a disease is total disappearance of the signs and symptoms of a disease with treatment. You would have listened to the diseases being put into remission like leukemias, lymphomas, and certain collagen vascular disorders like SLE. But in diabetes remission, it means return of blood glucose below the diabetic range, either spontaneously or following interventions, and which persists below the normal glycemic range for at least 3 months in the absence of glucose lowering agents. So there were a lot of confusions regarding this definition of remission. But however, joint statement that was issued by ADA, EASD, and Diabetes UK as well as Endocrine Society says that the remission is considered when blood glucose level where HbA1c is less than 6.5 or fasting blood glucose is less than 126 at 7 millimoles, maintained without any anti-diabetic medications for at least 3 months, and which has to be rechecked annually to confirm that they remain in that state. Now, there are 3 categories of remission, wherein first one could be partial, which means the patient is put into pre-diabetic stage, where HbA1c is between 5.6 to 6.5, and fasting blood glucose will be between 100 to 125. And we call it complete remission when the blood glucose is below 5.6 A1C and fasting less than 100 milligram, again, which is lasting for more than 1 year without any medications. And same thing when it is lasting more than 5 years, then you'll be considering as a prolonged remission. Now, why remission is important? You would have seen that the burden of diabetes nowadays, the cost of managing diabetes is very high nowadays because of newer anti-diabetics, which is mostly unaffordable for many patients. Even today, we may be reluctant to use certain anti-diabetic because of the cost, and it is so inhibitory. And cost is important factor when you manage with a lifestyle disease. And according to Pan India study, it was found that in rural areas, the average expenditure the family member has to bear for the management of diabetes as high as 1,000 rupees. And also, the why we should put the patient to remission is that it prevents the progression of the disease as well as it prevents the complications as well. Now, how do we achieve it? The remission could be easily achieved by surgical methods, which everyone knows about it. And my interest will be on a non-surgical remission, where we would be likely to put a patient into remission by just using diet and exercise. A surgical remission, as everyone knows, is a bariatric surgery, which is very safe and effective method for remission. which has been going on for a very long period of time. But only problem of surgical remission is it is suitable only for a small subset of obese patients or obese individuals with some complications. And it is well known that surgical remission could be achieved by up to 80% of the patients. Now, this study, which was done in Swedish obese subject who has undergone bariatric surgery for diabetic remission, it was found that at the end of 2 years, as high as 72% remain in remission. But then the chances of being remission gradually decrease over 10 years to 38% and 15 years to 15 to about 30%. And the good thing is that soon after the bariatric surgery, the changes which leads to remission of diabetes actually was visible within few days of the surgery, like increase in the betterment in insulin secretions and improvement in insulin sensitivity both at the hepatic level as well as peripheral insulin sensitivity. And all these things led to remission of diabetes, which was sustained more than 1 year period. Now, my interest is on medical remission of the diabetes. And actually, this whole idea was put forward by none other than Professor Roy Taylor. He is actually Professor of Medicine and Diabetology at Newcastle University in UK. And he and his colleagues started research on the reversibility of diabetes in 2008. And they started a small study called Counterpoint study with 11 patients put on a remission using very low calorie diet. But those days, he received a lot of criticism and he has to stop his study for some time. But later what happened was the public in the Newcastle picked up this particular diet and they started using on their own. And at the end of few months and few years, they found that they were losing a lot of weight. And many of them were actually free of anti-diabetic medications. And that actually forced the Newcastle researchers to pick up the data from the public and publish as a paper. And that is how actually the whole thing of non-surgical remission started. Now, when you are actually at the brim of having a lunch, I'm very sure this will be very tempting. The nutritional basis of diabetes and its reversal was actually addressed by none other than Roy Taylor. And you can see the Indian diet is very high in calories, mostly because of the carbohydrates. And we will find it very difficult to resist because every time, wherever we go out for a dinner, we will go out to visit a friend, everybody will force you to eat a little. So that actually a small increase in the calorie intake will make you really a patient who could have diabetes in the long run. So there is a saying that you are what you really eat. But sometimes I differ with that because I differ that you are not what you eat, but you are actually what you digest and assimilate. That's very important because when you consider having a food, you have to really think and eat because otherwise, in long run, if you consume the same food in a slightly excess quantity, may make you a patient. So nutritional basis of type 2 diabetes and remission was explained by the twin cycle hypothesis, which was put by Roy Taylor. And it is basically this particular idea was presented in the famous Banting lecture in 2012, where he actually mentioned about reversing the twin cycles of the diabetes. Let's see what is twin cycle. Actually, there are two cycles which is established to be involved in the pathogenesis of type 2 diabetes and the reversal. And one cycle actually happens in the liver. And this we are very familiar because we come across large number of patients with a fatty liver. When you eat little excess, as I said earlier, what happens is the extra calories get deposited in the liver. And over a period of time, because of the fatty liver, there will be a decrease in the insulin, the decrease in the failure to suppress glucose production, which leads to hepatic glucose output and increase in the fasting plasma glucose. And this cycle keeps on happening in the liver for some time. And once the personal threshold for the fat of a person exceeds certain limits, there is a spillover of the fat into the pancreas, which is a ectopic site, and pancreas. The fat depositing in the pancreas lead to the disruption of the beta cells. Gradually, there is an decrease in the insulin response to a meal-related delivery, and whereby there will be postprandial hyperglycemia and over diabetes. Now, if you are able to reverse these changes, that is, which leads to diabetes, there is an excess fat in the liver as well as infiltration of fat into the pancreas. If you are able to reverse that by decreasing the calorie, by decreasing the body weight, then we could easily achieve concept of remission. Now, I'll look into what are the dietary strategies that is involved in the remission. This could be done by a very low calorie diet, which is mostly used in experimental settings. But some people in and around are also practicing very low calorie diet using meal replacements. Then we mostly prefer to use low calorie diet, and some also follows low carbohydrate diet. Now let's see one by one. Very low calorie diet means the calorie that we prescribe in 24 hours, 800 calories. This is mostly given as a replacement meal in the liquid form. And this is given for about 12 to 6 weeks and followed by a reintroduction of a solid foods for weight maintenance. And all these diets, actually, they maintain 50 to 60% energy coming from the carbohydrate in the form of maltodextrin to glucose. with adequate high biological value protein of 1.2 to 1.5 grams per kilogram body weight. And the disadvantage is that it contains so little of fiber. So therefore, this patient may be at the high risk of having constipation, but still they do not have they mostly do not have vitamin or mineral deficiencies. A low calorie diet is one which we are normally following, where calories restricted to 1000 to 1500 calories, and which is provided as a healthy food plate method. That's a very popular method of restricting the calorie intake, and this is supposed to be the balanced and healthy one. Now, the patient will be having a freedom to choose the vegetables and the food they wanted to they enjoy eating. Only thing is, you have to advise them to fill half the plate with raw or boiled vegetables and fruits, and rest quarter plate with grains, and then the rest of the quarter with the lean proteins, which can come from either meat, chicken or fish, or any other vegetable source of proteins. Now, so there is another method wherein you can advocate them to take low carbohydrate diet, wherein the energy derived from the carbohydrate is less than 26%. Sometimes very low carbohydrate diet where calorie comes less than 10% is also being tried by some people, but it is not recommended when we treat diabetes. Now, this study actually is about the very low carbohydrate diet, otherwise known as keto diet, which was published in BMJ in 2021. It was found that it is useful for a short-term weight reduction and putting patients in remission, but in general, it is not useful for long-term methods. Now, apart from considering the dietary methods, what all patients you will be recommending to consider for a remission? Now, there's an easy way of choosing the patients by looking at the ABCD formula. ABCD formula means you must, A is for A1C, which means if you choose very high A1C at the beginning, it's likely that you will fail. So I would recommend to choose patients who are having A1C 9 or less than 9 without any complications or new onset diabetes. And body weight, B stands for body weight. If you choose obese and overweight, you're more likely to be successful and achieve remission. And if you can measure the C-peptide, it's actually a marker where you'll be successful or not. If somebody is having a normal or slightly higher C-peptide, then also that they may be the right person to choose because they will have a easy remission. And the duration is very important, because if you choose diabetic patients with duration more than 6 years, it is likely that you might fail because they will have a poor insulin reserve. And E and F is because you should choose all those patients who have got enthusiasm to do all these kind of restrictions and physical activity, and they must be willing for a follow-up. And if you adhere to all these ABCD formula, it is very easy to achieve remission. Then what are the evidences I have to prove my debate that patient can go into remission? All the evidences has come from this gentleman, none other than Professor Roy Taylor and his colleagues from Newcastle. The initial study which I mentioned, Counterpoint, was including only 11 patients who were actually obese and overweight, and then put them on a very low calorie diet for 8 weeks. They had a mean weight loss of 15 kg, and remission was achieved in 8 weeks. And they demonstrated by MRI that there was actually a loss of fat in the liver to a very great extent, from 36% to 2%, and there was normalization of the insulin sensitivity as well as secretion. Now, then subsequently they started another study called Counterbalance study to see that there was in certain areas there were patients who are actually not responded. They were actually mainly looking into people who had not responded to the dietary modifications. 30 cases of type 2 diabetes with a duration of 6 months to 23 years were enrolled. They were again put on very low calorie diet, and they found that at the end of 8 weeks, only 40% had remission, and those who non-responded had actually were not adhering to the dietary methods, and they did not lose much weight. Now, this is a landmark trial which tells you about the remission. This is actually called the DIRECT study, otherwise Diabetes Remission Clinical Trial, originally done by the Professor Roy Taylor. And this study actually was done in 10 sites in Scotland and England, including 280 participants with a duration of diabetes up to 6 years, where body mass index was 27 to 45, and the primary endpoint was weight loss up to 15 kg or normalization of the HbA1c. And they had a follow-up beyond 10 years. And again, they demonstrated the decrease in the pancreatic as well as hepatic fat by MRI, and also they did metabolic studies as well. And if you look at this slide, you can see at the end of 1 year, those who lost weight of 15 kg had a remission of 86%. But then you can see that the the remission is directly proportional to the weight loss. When the weight loss is less, when people lost less than 5 kg, the remission was as less as 7%. And they had a longer period of follow-up also beyond 2 years. They also have the data at the end of 2 years. You can see there was a decrease in the remission from 46% to 36% at the end of 2 years. Now, generally, if you look around, we can see that a lot of obese patients are having diabetes, and obesity definitely increases the risk of type 2 diabetes. But thing is that 10% of diabetes are not really obese or overweight. And then to see what can be done in these kind of patients, Roy Taylor and his colleagues started another study. They assume that body mass index may not be that significant in defining type 2 diabetes risk of remission as previously thought. And then they started analyzing a hypothesis called personal fat threshold, which means a specific amount of fat in a person that a person can store, after which they are more susceptible to type 2 diabetes and associated illness. The gentleman on the left side of the screen is lean and thin. He looks fit, and the other guy is looking obese and not fit. So the thing is, if the lean man keep on eating excess quantity of calories over a period of time, his personal threshold for fat deposits exceeds, and eventually he will develop more fatty liver and more fatty pancreas, which will actually lead to diabetes, unlike the other person who has got little excess capacity to fat storage. That is what is actually about the personal fat hypothesis. And to see the reliability of this hypothesis, a retune study was done. Retune means reversal of type 2 diabetes after normalization of the energy intake. This study was again done on those patients who are not really obese, slightly overweight, and they put them on 3 cycles of 5% weight loss over a period of 2 to 3 weeks on a very low calorie diet, and then again weight stability after about 6 weeks. They found that they also went into a remission. And the statement that was made by Roy Taylor is that anyone with type 2 diabetes need to lose weight even if they have a BMI in the normal range. And type 2 diabetes could easily be put into remission if they lose 10% of weight. Now, there's a very interesting study by ICMR, INDIAB study, which is conducted nationwide based on the data-driven optimization model, and they have recommendations macronutrients for remission as well as prevention of type 2 diabetes. You can see that ideal meal composition, if you wish to achieve remission, is that marked reduction in the carbohydrate content. As I have said, Indian diet is rich in carbohydrate, which may vary from 65 to 75% depending upon the region. And ICMR study recommends that if you can recommend a diet which is containing 49 to 54% of carbohydrate, and then rest coming to 20% of protein, and then another 26 from fat, can easily put a person into remission. Similarly, if you want to stop the progression, then maybe you will have to increase the carbohydrate a little bit. But then definitely the catch is in the carbohydrate. If you can reduce the carbohydrate, and then definitely you can put them into the remission. And also there is another important thing to mention about while eating. Many of us actually start eating the rice, chapati, whatever it is. Then probably that may not be the right way of eating. And if you choose a sequence to eat, like you eat non-starchy vegetables and fruits first, and then consider eating proteins and whatever fat you want to eat, and then last, if you choose carbohydrate, that also will slow down the digestion assimilation, and then thereby glucose variability could be reduced and easily control the postprandial blood sugar levels as well. Now, as the old Indian saying goes, the one who eats once a day is a yogi, and the one who eats twice a day is a bhogi. And if you really eat more than twice a day, probably you may become a patient with type 2 diabetes and other associated problems as well. Now, there's an interesting article published in the New England Journal of Medicine about intermittent fasting and its benefits in health and aging. It's very narrative article. Actually, everyone should go through it. I'm sure more than 50% of this audience would have gone through this. If not, please refer this article. But it mentioned about the benefit of intermittent fasting in health and disease. And this is an article which has looked into the intermittent calorie restricted diet in remission. It was found that 47% of the patients who participated in this study had a remission after 3 months. So that means it is the calorie that is important than the type of food you consume, and you definitely have to reduce the calorie that comes from the carbohydrate. Now, we have a program in our hospital in Rssdi Kannur called a dream. The dream, every patient with type 2 diabetes has a dream that they should have minimum drugs, or they should either be off the drug. To materialize that dream, we started a project called Diabetes Remission with Exercise and Diet in Rssdi Kannur. And this program we started in pre-COVID actually, in February 2020, but unfortunately the COVID washed off the program. Then we relaunched 1.5 years ago. I have 10 patients enrolled for this program, where the diabetes duration ranges from 6 months to 3 years, and male-female ratio being 9:1, age varying from 35 to 55 years, and body mass index was average 30 kg per meter square. And A1C, when I enrolled them for the program, I choose those patients with 7.5 to 8% because I wanted to keep all those patients less than 9%. And weight loss at the end of 1 year varied from 8 to 10 kg. And I had 50% remission, complete remission, and 50% partial remission. That this is something very encouraging for me. That's why I said the remission has been made a reality by few of my patients. And to conclude, remission of type 2 diabetes is a reality. And it is what is important is to proper identification of the candidates. That will only depend on how successful your program is. And normoglycemia can be maintained easily with the dietary modification, even in the absence of significant weight loss. But only problem is relapse may occur if the carbohydrate restriction is not considered. And in India, the major challenges we have is the restriction of carbohydrate on long-term basis. So it is your choice to choose what you want. You can go green and be fit, or you can choose the other side and become obese and diabetic. Thank you very much for your patience.
So in an excellent presentation, Dr. Hanif has supported the view of Professor Roy Taylor, Halberg, and Funko. Let us hear the other speaker. And it is none other than Dr. Raju Gopal, endocrinologist. And let me introduce him. He is the MD, he completed his MD in internal medicine from the Kottayam Medical College. And he has the DM endocrinology from the famous Seth GS Medical College and KEM Hospital, Mumbai. He was awarded the FRCP by the Glasgow University in the year 2020. And he was also elected as the fellow of the American College of Endocrinology and working as consultant endocrinologist for the past 14 years. I think he was the organizer of the Mendos and other several academic events, and he is an astute endocrinologist with excellent clinical skill, and I am knowing him for last several years. It's a pleasure to invite you, Dr. Raju Gopal, who has a very high interest in researches with more than 33 presentations in the last few years. So over to you, Dr.
Thank you, sir.
And
Hope I'm audible.
After the deliberation, the chairs will take over the session and they will go for the discussion.
Yeah. Hope I'm audible. Thank you,
yes,
sir.
Yes.
Thank you, sir, for the nice introduction, and good afternoon all the delegates in the police and media side. And also I thank Rssdi organization officers for inviting me, especially Arjun and Balakrishnan sir. So before I start, my today's talk is about diabetes remission. I'm not supporting the remission. I'm saying it's a real. So what I'm going to present next, I will be making my presentation very short because most of the background data has been presented by Hanif sir, and thank you for that. And so I'll be presenting my views in probably in next 10-15 minutes. So before I start, I would like to say
share your
all
slides.
this debate. Yeah, it's not being shown. Slides are not shared. I'm sorry.
Not yet, sir. Not yet. Can you share? You have been given access. Yes, sir. Slides are visible.
I'll put it in the presentation mode.
Yes.
Can you see me? Yeah, can you?
Yes,
is it visible now? Yeah.
Yes, sir. Yes, sir.
So what I want to say is the whole debate and discussion, the remission, we read as and understand as a long-term remission, not a short-term remission. And diabetes remission with lifestyle modification drugs are mostly considered. I think Hanif sir also said the same thing. So we have a set of post-bariatric surgery remission, which I'm not discussing much. So what I'm going to discuss next 15 minutes would be what are the problems with the definition of diabetes remission, what are the problems with the candidate selection, the modes of intervention, how they are deficient and how they are inefficient, and what are the variables in diabetes to be considered and not being considered in this mode, and temporal features. And the most important thing is really reproducible in the real world real world? That's the question we would like to get an answer. So the optimal terminology, as you all know, the resolution, reversal, and those and cure are being taken on. So the guideline committee has, in 2022 had said that remission would be the most appropriate term to be used when this context is concerned, not cure, because as you all expected, it is not going to happen. And the likely criteria to diagnose remission of type 2 diabetes is HbA1c less than 6.5, remaining at that level for at least 3 months without continuing the usual antihypertensive treatment. So this is the definition for the remission. And the factors which can affect HbA1c, you can consider ECG or estimated A1c from CM, or fasting plasma glucose less than 126 can also be considered an alternative in some settings, and OGTT is not generally considered. So we have HbA1c. The HbA1c cannot be calculated. You can go for eCGM, eHbA1c from CGM, or you can go for a fasting plasma glucose less than 126. What are the problems in this definition? The first and most important thing is 3-month criteria for definition extremely short for a disease like type 2 diabetes, which is very, very chronic in nature. And HbA1c is highly variable and it is monitored with respect to methodology, and it has to be repeated the same method. When you say HbA1c has been maintained, we have to use ideally the same method, same lab, and same methodology by which the HbA1c is being transferred. I think most of you are aware that HbA1c could be done for various methods. And CGM-derived A1C can be used. Suppose if you don't have a A1C, it cannot be considered. I mean, it cannot be taken into account as in case of hemoglobinopathy or anemia. You can go for ECG. But the problem with eA1C is that is not well standardized. So what you are actually using may not be the actual. And the second thing, you have to repeat the HbA1c at least once in a year, or more than 3 months, or at least once in a year. But if you are using it once in a year, it will be very, very inappropriate to say the patient is remaining in remission, because patient can go back to the diabetes in between. So defining remission with the 3-month data, it cannot be considered truly as a remission for a disease like diabetes. This is a problem with the definition. Next, the candidates of remission. So as already Hariu sir said, that not all patients are considered as candidates for remission. So now some studies which he has shown, probably remembering counterpoint and the counterbalance. So if you see counterpoint was the first study, and the counterbalance the second subsequent study they have taken to prove the hypothesis, in which they have taken patients with history of diabetes from 0 to 23. And the reason why they had a lesser remission in that group was because of the patients with a long-term disease have got a lesser rates of incidence. Actually, in that study, you see, they have divided the patients into 2 groups. One, those patients who had remission, and one patient didn't have remission. And those patients who had remission had always had a lesser disease course, while long-term patients actually did remission. It was not because the patients actually adhered to the diet, it was because of their length of disease, duration of disease was much longer. So only patients with the long-term, short-term disease, the early course of disease are the candidates for remission, which actually, as you all know, will not comprise only a short number of the whole diabetes group. So patients with shorter duration, lower OHA use, and the patients with higher baseline C-rate are the patients who are likely to get a better result when you are subjecting this patient for a very low calorie diet. That's what's been shown in this counterbalance study. So we have to select the patients in this group if we want to have a good result in terms of remission. So this is what the problem I want to say, that type 2 diabetes is a very progressive disorder, and it's only absolute truth that diabetes will always progress. It is only absolute truth with regard to type 2 diabetes. It's only useful in early diabetes, if at all, and even if those patients who are controlled cannot be hold good for long, because today's treatment will not hold good for tomorrow. And early diabetic who comes under remission will progress, and short-term remission cannot be considered as important in disease like type 2 diabetes. Now look at the modes of intervention. There are three modes of intervention generally being considered. One is pharmacotherapy, second is lifestyle modification, and third is metabolic surgery or bariatric surgery. So if you see the remission data in patients with intervention, pharmacotherapy, lifestyle, and metabolic surgery, are they different? They are actually. So physiological mechanism you put into with a pharmacotherapy is you are just looking at the reversal of the adverse effects of poor metabolic condition. And the lifestyle changes actually is much more deeper. Patient has to change his lifestyle in terms of dietary habits, improving the physical activity, stress management, and so on. And metabolic surgery, you are doing little more harder on hard points, like you are making a structural change to enhance the GLP-1 level and decrease the satiety. It also alters the peripheral metabolism. So you are looking at a different level in the metabolic surgery. So considering pharmacotherapy and lifestyle, this is the thing that would happen. So what the direct effect is going to be? So direct effect as far as pharmacotherapy is concerned, it gains very fast. While lifestyle, it can stay longer, depending upon the type of lifestyle change the patient actually adopted. And metabolic surgery, as expected, to stay longer. And long-term remission is lowest with pharmacotherapy, is variable with lifestyle, and highest probably with metabolic surgery. So what are modes of intervention? What are the problems in that? The metabolic surgery is usually helpful obese and morbid obesity patients with type 2 diabetes. Generally, it is not even now the standard of practice to operate patients with type 2 diabetes just for the diabetic control. Mostly it is being studied, used in patients who are extremely obese and morbid obese, where they have a diabetes, and because of weight loss, these patients lose a significant amount of weight, and they lose, they are becoming non-diabetic. So lean patients, it cannot be adopted in the same way. And the results also vary from the type of procedure. I think Hari sir has told that it can go up to 80%. Actually, the highest reported remission rate with bariatric surgery is 75%, which is actually with a much more radical procedure like biliopancreatic shunt with double slit, which generally we are not doing. Ruined by gastric bypass or liver gastrectomy do not have that much that level of remission rate. Usually it varies between 25 to 30%. We are looking at the data of 5 years. And very few studies have long-term diabetes remission data. We have at least 4 or 5 studies which have shown this is the remission rate is reported. And most commonly performed surgeries, which is about 20-25. And the second part, which we are not discussing, is the adverse effects associated with bariatric surgery. I think most of you are aware that it is associated with significant adverse effects psychologically as well as physically. So apart from metabolic surgery, other treatments do not offer a long-term remission. So behavioral change is one thing you actually looking at with the lifestyle modification. It's the toughest thing in the world, and in the real world, it's extremely difficult to achieve. And even if you achieve, it's difficult to sustain because of without the constant reminding, constant motivation, it's extremely difficult to sustain. And drugs, if you see, apart from GLP-1 and tirzepatide, that is a dual GIP and GLP-1 agonist, the effect is very modest with other agents. And in case of we are using a GLP-1 and a tirzepatide in a patient with for the prevention of diabetes, for the remission of diabetes, probably you are actually treating them slightly early. So what are the variables actually in the type 2 diabetes development? One is genetic predisposition, second is environmental factors, third would be association. And there'll be a lot more, I'm sure about it, but the major three would be these three. So when you are looking at this very low calorie diet or other pharmacotherapy, you're actually not addressing any of these factors comprehensively. Except for weight loss and incretin acid modulation, none of the pathophysiological aspects of type 2 diabetes are being addressed when you're using this therapy. And as expected, it will not produce a significant change. Now, the temporal features, I think I've discussed earlier. The time frame which we discussed for at least 3 months, and for lifestyle modification, this intervention is for 6 months. So this is quite inadequate for a disease like type 2 diabetes. And the longest follow-up data is for direct extension study. That's what if you're looking at the dietary modification and remission, the longest is the direct extension study, and just got a data of 5 years. So what is it shown? Those patients who remain at end of 2 years in diabetic remission. Out of 85, 48 remained in the diabetic remission group, of which only 11 patients could remain in that remission for next 3 years. That is, at the end of 5 years, 11 patients out of 85 at remission, which is not to be said in a great way. So, the temporal features, the problems are 3 months is very too short, and longest trial data with lifestyle modification and dietary modification is 5 years. It actually happened in a trial setting. You cannot extrapolate in the real world setting. And metabolic surgeries have got a better long-term result, which as I mentioned, I am going to discuss much. The most important part of the discussion is the reproducibility in the real world. So, as I mentioned, longest data for lifestyle and diet is 5 years. It is extremely small number considering diabetes, the number of diabetes we are looking at, and it's basically a trial data. And patients with short-term diabetics were involved in the study. So, this could not be extrapolated into the real world. So, this is like a long-term data is not available. And as we all know, type 2 diabetes is a heterogeneous population. And we are looking at not a study design in a real world. You are treating patient by patient. It's practically impossible to extrapolate in a real world. So concluding my session, the current diagnostic criteria cannot be applied in the real world setting. It's an extremely heterogeneous population. Data from intervention modes are insufficient for long-term remission. The temporal profile is not acceptable for a disease like type 2 diabetes. And for type 2 diabetes like this definition and small number data should be highly theoretical. It can only work as a pilot study. Look at the pathophysiology and the reversal can be discussed in that. This cannot be extrapolated into a real world practice. This is what I believe. And diabetes remission is like some feeling, like which comes with a teaser or a trailer, says so much about. And we always believe the trailer, the picture is, the film is going to be great, but that's only the trailer is the only thing. There's nothing called a film after this. So diabetes remission, I feel it's a big real. It's not a real thing, it's a real real. Thank you very much for the patience.
So Dr. Rajagopal is telling that Rajagopal is telling it is a hope and there is a lot of hype. And over to the chairpersons, take the sessions for conclusion.
I think can you hear me?
Yes, yes.
Okay. It was an interesting debate. Actually, both the speakers, Dr. Rajagopal and Dr. Hanifard, explained beautifully about the new term that is a diabetes remission, how you can achieve, and the each diagnostic criteria, the pros and the cons of the diagnostic criteria that explained well. But I like the term real nowadays because the new gen people are more bothered about real. So any questions from the crowd? I think I have seen one question because somebody was asking about some dietary products which has been given some remission of diabetes. I think I have one question. I think many of my patients stopped insulin, starting Herbalife products with improvement in their sugar levels. I don't know if any of the speakers can. I'm not so much advocative of these products. So
Actually,
speakers can discuss about this.
Yeah. Actually, last January, February, Roy Taylor had come to Trivandrum. I had an opportunity to meet him, and what they are using is a powder type. But I don't know whether that thing will be suitable here, because I'll tell my personal experience. I was 108 kg around 5 years back. So now I am 70, 76, 77. So I made my own diet, like less of carbohydrate. I'll take only afternoon also very less rice, and take more vegetables, fiber. So we around 800 kilocalories for the last many years. Now I'm maintaining in this. So in that way, I think we should suit to our thing, because outside they'll telling lot of powders and other things, but we can make our own products, and with the help of a dietitian and a doctor, we'll be able to maintain the blood pressure. And even Roy Taylor studies has shown that if 15 kg we get more remission, and if the patient has only 10 kg weight loss, remission is not possible. 5 kg also that much remission is not possible. Only if you are maintained so that our pancreas fat will come down and the liver fat will come down. Through that mechanism, we will be able to maintain the weight loss. What is our opinion?
I think if they have both the speakers has to give if it a balanced view, or I think they may have some more thing to say, because it is all the second person has discussed. I think if they have to say anything, they can discuss.
Actually, someone has raised the question about Herbalife. It is actually a feed which is having a very low calorie, similar to the composition of what we use. And patients have actually reported that they have lost significant weight, and many of them are either on a very minimal number of oils or even reduced units of insulin. And definitely they have had benefits by reducing the calorie intake. That is one thing. And secondly, I found self-reported intermittent fasting. People really fast. Religious grounds they fast. That has been there in India for a very long time, Monday and Thursday. And intermittent fasting as well as time-restricted feeding. They have a window of eating for about 8 hours a day and they do not eat anything. This is not based on any scientific principles. They actually have adopted themselves. Then later, when we come across these kind of reviews in the journals, that what they have been following up is really good. And I have asked them to continue for a longer period of time. I know many people fasting are adopting intermittent fasting and time-restricted feeding for more than 15 years. Having very good weight loss, very good blood sugar control aspect. But in general, it is very difficult to maintain the longer period. Remission is a new concept. We should not say that remission is quite possible. Only thing is we do not put any effort from our side to explain that there is a possibility or a concept called remission, and it is possible to do by certain methods, because many a time we are so busy in our OPD, we have only time to write a prescription. We do not interact them in a way that they get convinced about the dietary modifications and other lifestyle modifications. So yeah, I think hereafter we should be giving them an option of intermittent fasting, either to 5:2 or time restricted feeding, where they reduce the feeding interval to few hours in a day. That definitely brings out wonderful results. Definitely, Herbalife has proven beyond doubt that they do bring down the weight loss significant level and also remission of diabetes. But the only thing is we will not be able to recommend such diet because that is not physiological when it comes to control of diabetes.
Dr. Raju, any comments on this point?
See, regarding the statement that once you have weight loss, this is going to happen, that remission is good enough. But the active mentioned, it has to be a significant weight loss. To achieve that, it's very difficult to achieve that in a real life situation. That's only my point with regard to this thing. Regarding this particular product, I actually, as Dr. Hanif said, I have seen 50 million patients have lost weight. I don't know exactly what it is. And that the reason why we cannot recommend it because we don't know what exactly it contains. And probably it may have something. But weight loss is something which we have observed in that product. I don't know what exactly it contains that. And I can't recommend something which I don't know what it contains. So that is a problem.
Actually, whatever it is, the basic management of diabetes itself says you have to stick on to a proper diet plan, the drugs and the exercise. I think the remission may be a new terminology. I think what suggestion we can give to our patients is we stick to a proper diet plan, as we discussed from so many years. It is that low calorie diet, and my personal experience is intermittent fasting is up to some extent. Those who can plan it, it is a useful tool. I don't have too much of pro towards the metabolic surgery, because still it is not what are the later complications of metabolic surgeries, nobody knows. It's still a debate topic. So anything from Harish's side? I think he's unmuted. Sir,
I will just hello.
Valiot sir.
So I think that very good things will have an end. So we would like to hand over the platform to our Rssdi office bearers, and
yes, I think it's running short of time.
They will conclude the session, and they will give an opportunity for our secretary to have a vote of thanks. I think they will invite us for concluding the session and handovering the platform again to the officer. Thank you.
Okay, thank you, Dr. Baleshnan, Dr. Arjun, Rssdi Kerala chapter, Vijay Kumar sir, Suresh, for giving us opportunity to share this session.
Okay, we have to take a group photo before we conclude. Actually, I think it's time for that before going to the final session. Reshma, can you please? Can everybody
Switch on your video, please, all.
Hello?
Vijay sir, Kana, you are audible.
Okay. Visible also.
Visible, no problem.
Okay.
Okay, video on.
All delegates, please switch on your videos.
So we are going to click 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
സുരേഷ് ഫോട്ടോ എടുത്തതിന് ശേഷമാണോ എല്ലാം എന്ന് പറയുന്നത്?
Ayo, Reshma?
Sir, just everybody wait just 2 minutes.
Okay.
Vijay Kumar sir looked in front, otherwise, yeah.
Okay.
Okay. I think it is done now.
No, sir.
Yes.
One click sound had come.
That is, she's taking in parts, sir. It will take little time.
Okay.
So, ഞങ്ങള് ബാംഗ്ലൂർ ADA സാറേ.
മനസ്സിലായി. ബാക്ക്ഗ്രൗണ്ട് കാണുമ്പോ മനസ്സിലാകും.
പ്രസന്നകുമാറുണ്ട്.
It's done, sir. It's done.
Okay. Now
it's done, sir. It's done.
Okay, thank you.
Okay.
Secretary and Chairperson, Rssdi Kerala.
With regard to this meeting, what I have to tell is this is the most satisfying and rewarding meeting during my 1.5 years of tenure. In terms of number of participants and in terms of one thing, the most important thing is that not having to pay anybody and also without any pharma support, and the highest number of participants and the most active discussions and deliberations and high in scientific content and best of speakers. That's what all I have to tell. And I think I should thank the organizers and all the participants for giving us this wonderful treats. Thank you very much.
Thank you.
Yeah. Thank you. One word. Thank you, the Kannur team, led by Dr. Joe, Dr. Balakrishnan, and Dr. Arjun for an excellent conduct of this meeting. I think we will meet in Kannur sooner than later for a physical meeting. Thank you very much.
Thank you, sir. Thank you.
Bye. Thank you very much. So
Thank you. Bye.